Hello, sir. Good morning. Hello. Can you hear me, Mr. Gopalakrishnan? Can you hear me? Hello. Kindly respond if you can hear my voice. Hello. Good morning, ma'am. Can you hear me? Hello. Hello, good morning all. Can anyone can hear my voice? Please respond. Hello. I request you to respond. I just want to check whether you can hear me.
Yes, ma'am. Good morning, ma'am. You
Yeah,
can
good morning.
audible, audible.
Thank you, sir. Thank you so much. So, good morning all. Today we are going to see about alcoholism and dependency. So, before that, I would like to thank the principal of Mother Teresa Postgraduate and Research Institute of Health Sciences and Directorate of Distance Education of Pondicherry University for giving me such an opportunity to share my thoughts and words regarding your syllabus in this alcoholism and drug dependency. I hope others will be joining us soon. So I'm starting with we know this word alcoholism and drug dependency very commonly. Um, it became very common in all the countries nowadays, and even drug-related disorders or any other side effects, everything is almost known to all of us. So we are going to see about few things which which is causing this drug dependency and how to manage them and how to prevent them and how this de-addiction and the rehabilitation centers are being working and what are the centers available which was created by our government, everything we're going to see today. So we know that drug related disorders are many and we don't have any specific place for treatment, but once if we get into this rehabilitation centers, there we will be having some um, treat some kind of treatment where the patient is extremely in worse condition. So these centers are exclusively created for such patients who are who are unable to get rid of this addictions of any drug abuse or any other alcohol or anything. And we know that 1 in 5 among the deaths which is being happening is due to this alcoholism or any other drug abuse, and mostly the 30% of hospital admissions is due to because of drug abuse and alcoholism. So alcoholism we know it commonly, but drug abuse it doesn't mean only this narcotics. That is what we know it very commonly, that like morphine or cocaine. That is what we know it commonly. But the drug abuse can be maybe because of usage of some sedative drugs, means or normally when or painkillers or any NSAIDs, whatever they are taking, when they are taking it in overdosage. So that is also called as drug abuse. Means few persons, so when they are addicted towards this sedatives, so without the consent of the doctors or without any getting any suggestions or any prescriptions from the doctors, they themselves they are taking the sedatives in more than like in overdosage. So they which is causing them to take into some different so where they feel some pleasure and something, so they are getting addicted into that. So, usually this can be found either the drug abuse patients or any alcohol patient can be identified based upon some symptoms that is like drug related. So, when a patient is presenting in a hospital with any overdosage or any intoxication of more usage of tablets, so with that, a doctor can doubt the patient, and they can identify that the patient is doing some drug abuse. Or else when they are going for any other checkup, like when they are addicted, or when they are doing some drug abuse with some other medicines, they may have some side effects. And for those side effects, when the patients are getting into the hospital, based on that side effects, the doctors may identify while screening any lab tests or anything, or any physical conditions or any drug levels in the body. So due to this means finding those symptoms, uh, the doctors can identify that the patient is alcoholic, or the patient is doing some drug abuse. So usually, the drug abuse and the dependence is done means by the patient under a few circumstances, where when the patient is having some social problems in their marriage life, or they have any they are facing some domestic violence, um, irrespective of any genders, or when they are facing some pressure and stress in the works, or any other sexual problems, or when they face any unexpected financial or legal issues, uh, they get into this kind of addictions. Other than that, they also come along with some other psychiatric problems. So when they are having some, normally what we know is like anxiety and depressions that may cause some alcoholic or drug abuse. But other than that, also like irritability means where they are when the patient is not able to be so patients in either in work conditions, working atmosphere, or in their social life, when they are um, not able to face anything patiently, and they are getting irritated, or if they have lack of sleeps, or when unknowingly they are getting into repeated accidents, or when they try to harm themselves, or when they are not doing their own normal personal cares like self hygienes or day to day activities, when they are not following all this, obviously they are getting into some psychiatric issues. Along with that, when they will be having this addictive problems also. So, if at all, if the patient is, even though if they are not having any alcoholism or drug addictive, this kind of situations with push them into some addictive characters or addictiveness. So they have to be monitored and they have to be treated, or without even when a person is asking any medication in the pharmacy over the counter, like hypnotic drugs or antidepressants, or any other psychotic medications, if they are asking without any prescription, so that may be also a starting stage, or it may be at any stage of this addictions. So that is easy for us to identify the patient that they are in some dependency of some drugs. And if the patient is having any history of many consultations with different doctors, so usually they never they are changing the doctors, means they are not following up with the same doctors, because when they are asking for more drugs like sedatives or any antidepressants or analgesics, and if the doctors are not providing them as they ask, means why the doctor won't provide, means we have some norms and protocol that those psychotic drugs has to be taken in some schedules, and it has to be followed very strictly. But when because of this, when the patient is not able to follow this schedule, obviously they are quitting consultation with that old doctor, and they are trying to get into consultation with another doctors. So if the patient is having several different consultation history also, that also means that they are in this stage of drug abuse or any alcoholism. So all these situations in a patient, that may that is when we are analyzing, when the doctor is analyzing the situations of the patients, we can find that they are in some stages of this drug abuse, and we can start treating them. So coming to the general drugs of dependence means which is causing addiction. So normally we used to know that like cocaine and morphine, but other than that we have some hypnotic drugs or sedative drugs which will be causing some dizziness or any like half sleepy situations where uh, where the patient is not completely they will be unconscious or asleep, but they won't even be in conscious of what they are doing. So usually the central nervous system depressants and stimulants will cause such kind of addictions, including nicotine and caffeine also. And opioid analgesics, narcotic drugs like heroin, morphine, pethidine. So these are severe kind of drugs which will be causing some uh, addiction. So when they are get to used to it for any other, when they are getting into the treatment of any other diseases or any other wounds or painkillers, when they are doing that, they are getting used to this kind of drugs and they are using it continuously means they are getting addicted to it. And these antitussives, hydrocodone and folcodine, is very commonly used drugs for common cold and cough. Even that is available along for kids also in certain dosage forms. So when the patient is having some knowledge that these kind of drugs will be causing some addiction and they will give some pleasure for them when they are using it, they will continuously start using it without the knowledge of the family members or even with the doctors. So other than that, when you go for alcoholic drugs like normal alcohol or methanol, even toluene, paint thinners, and petrol, which is really very shocking for us to know that some patients are even consuming this kind of solvents because of some addictions. And all the other psychotic drugs like LSD, lysergic acid diethylamide, and psilocin, dimethyltryptamine. All these drugs are psychotic drugs which will be causing some addictive characters to the patients. So next is a set of questionnaires, means how the patient or how the doctors can find that the patient in which stage of this addiction. So it is called as a cage questionnaire. So it consists of four questions, which they are using for diagnosing this alcoholisms. uh, this method is a very reliable method to find the stage of the patient in alcoholisms or even for drug addiction also. So the cage represents C for cutting down, A for annoyance by criticism, and G for guilty feeling, and E for eye openers. So this kind of diagnosis should be done by the doctor to the patient when they are sure that the patient is a drug addict or in drug abuse. So this is an old method, this cage questionnaire, and which is now modified with another set of questions, means for including the drug abuse. So how a doctor should ask the patient means. Um, they have to analyze the stage in which whether the patient is able to stop the use of alcohol or any drugs by some motivational or some encouragement, or whether they have to go for any substitutional methods, and whether the patient is feeling guilty about using it or he's happy about or he's happy about using the drugs continuously and he has no idea for stopping those. So, according to that, to analyze all this, according to this, this questionnaire has been modified. So, they have to ask the patient whether the patient is ready to cut down alcohol intake, or else whether the next question is like whether the relatives or friends, if they are criticizing the patient about this usage of drugs or alcohol, whether it is triggering the patient to take it more or to stop more. And next is about whether the patient is feeling guilty about taking the drugs or alcohol, or whether he never he's not minding even about others talking, or whether not feeling any guilty. So that is another stage. And the last one is like if a patient is either taking an alcohol or drug in a day, so then whether for stopping the hangover, whether he needs another drink in the next day morning, early morning after waking up, whether he needs another drink to stop that hangover. So that is actually an extremely worse condition, whether daily the patient needs this. So only if they are taking it in overdose. So this kind of hangover will be there for an alcohol or drug use. So that in order to make them steady, or in order to avoid those side effects of those alcohol or any drug abuse, they need another dose of drug or another drink in the morning. So that is called as an eye opener machine. So these four questions, when the patient is answering these four questions, the doctor or the clinician is able to analyze the almost the exact stage of the addictive stage of the patient. So when the doctor is sure about that the patient is addictive for alcohol or any drug, so they have before starting the treatment, the whole history should be um, heard, and it should be considered along with the medication. So that will give you the history of the patient, will give more information about the kind of drugs or alcohol, quantity of the alcohol, or how frequently they are taking, and how long they try to whether stop it or not, everything. So based on that, they can start treating, which will be easy for the doctor to treat the patient. So they have to go for the personal history along with the family history also. So the necessity for the family history is to check whether the family situation made the patient to get into this addiction or not. So they have to ask about any medications, whether they are taking, or how it started, whether it started like a social drinking a week, or with the friends, or in what way he is daily able to take this alcohol, he or she. So this all this information should be analyzed to check the pattern of drug use or alcohol use, and the quantity consumed per day or per week or month should be analyzed, and according to that, uh, the treatment should be started. And they need to find the reason why the patient got into this addiction. Uh, so that will give us more ideas, means that will help a doctor to stop the addiction of the patient more easily. So next, the doctor should analyze the patient's attitudes towards the drug use, means whether he is worried about others concerns, or whether he is worried about his own action, which is uh, which is disturbing their family circumstances, or whether whether he's ready to leave this addiction, or his willingness to get into participate into this rehabilitation. Everything should be analyzed. Only with the cooperation of the patient, this the addictions can be totally these de-addictions should be totally can be done. So without the cooperation of the patient, it is very difficult. Even if we try to achieve de-addiction, soon after the de-addiction, the patient will get into the addiction again. So only if we find the root cause of this uh, reason for the addiction, find and try to remove that situation or the cause, the patient may be easily recovered from this drug abuse or any alcohol use. So mostly the patients, the reasons for the patient who is getting into this kind of addictions is about the family history of the alcohol. Means either the parents or grandparents or any relatives who got into this, or any childhood abuse, or if the patient is if the patient is involved, means if he has been treated very violently, or he or she himself got into any crime knowingly or unknowingly. So at that kind of situations, they don't know how to face that about the future, or the anxiety of the problem, anxiety about analyzing these issues. They are getting into this history of alcohol or any drug abuse. And also, just in case if the patient is already got into any rehabilitations, or any got into any other agencies where to stop these alcoholisms or drug abuse, like Narcotic Anonymous or Alcoholic Anonymous, um, the doctor can get more information about the patient from these agencies. But this is possible one and only if the patient have tried into get into this kind of agencies, and to try to quit the drug abuse or alcoholism. So if at all, if the patient would have tried in that, the doctor can get almost answers for all their questions before the current situation, means before diagnosing the current stage of the addictions of the patient. So this agencies like Alcoholic Anonymous and Narcotic Anonymous would have been collected more and more informations, and they would have tried to give either by substitution therapy or any other cognitive or behavioral therapy for the patient. And so it would have been easy for the current doctor to do that. So next one is about to means to confirm the stage of addiction by examination. Means usually when it comes to this drug abuse, mostly the patient can be uh, identified by this needle tracks, or the inflamed skin, or any scars in the skin. And if they are trying to take through pulmonary, means like inhaler way, this nasal mucosa have been totally disturbed, and the pathological conditions of this nasal mucosa can be analyzed to find it in which stage are they. And uh, and about the mental stage, while examining the mental stage of the patient, so we can find whether how conscious the patient is, or he is in half sedation state, or the constriction of the constriction or dilation of the pupil in that stage. And or disinhibition means willingness to do some other work, or lethargic feeling of the patient. So that should be analyzed. And if the patient is under the treatment condition by any other agencies, or with any other doctor, or in any other rehabilitation center, but when he is unable to have a control about to stop these drugs, they will be having these withdrawal symptoms. So these withdrawal symptoms are like, um, since the patient is an addict, so the body is getting used to get the drug in exact some time related frequencies or any intervals. So when the body and the organs are not getting those abused drugs in particular time. So both their body and mind starts giving some side effects, or like any other symptoms, showing some symptoms like tremor or sweating, or piloerection, or any pupillary dilation. So that is very common when the patient is undergoing rehabilitation, means de-addictive stage with any other symptoms. So, other than this, when the patient is taking the drugs for very long time, prolonged drug administration is found, if it is found in a patient, so that may even cause hepatitis to the patient, like lung diseases, inflammations in the liver, and heart problems like arrhythmia or cardiomyopathy, and cellulitis and thromboembolitis is like uh, cellulitis can be found with the skin, means where the scars can be found in the particular places where the patient is continuously trying to intake the drugs, and thrombophlebitis is nothing but inflammation in the vein, uh, which is caused by any clot of any drugs. So, with that kind of pathological conditions, also we can find that the patient is in particular stage of addictions, and we can find the we can analyze the stage by the cognitive functioning or any mental status or the readiness for the change, means readiness of the patient to get change from that current situation, that also should be assessed. So next step is the lab investigations, where the patient should be uh, done with full blood counts, all the liver function tests, because all this alcoholism or drug abuse will affect in a major way of the liver, because liver is a metabolizing organ of our body, and we have to screen for HIV or viral hepatitis, because when they are using some needles, so this kind of contagious disease is possible with all the patients, and urine drug screening can be done to check whether how much drug is being eliminated from their body. So that may even give us an idea about how much drug is there accumulated in the body, or how much intake is done. And similarly, blood alcohol level. So we can check the alcohol content in the blood. So usually, when the patients are coming for any lab investigation for any other effects of disease, if usually if there is a rise in corpuscular volumes, like corpuscular means like raised RBCs or WBCs, or platelet counts, or any differences in that, or increased glutamine transferase levels, if these two levels are raised a lot, then it means that most likely the patient may have an alcohol addiction. Almost like among 100%, 75% of the people who are having this two levels high, they are alcoholics or any drug abuse patients. So we can analyze, or we can even confirm that the patient is addicted based upon these laboratory conditions. So next, coming to treatment. So this can be done by an doctor who is ready to reduce, prevent, and treat the substance abuse disorders, who are exclusively trained for this kind of rehabilitation treatments. So they have to go for the history, as we discussed before. They have to analyze the history and the physical conditions, and the all the laboratory conditions, or like biochemical findings, and their psychosocial problems, means their family history and their cognitive status. Everything should be analyzed, and it should be explained in detail to the patient before starting the treatment. And in case if the patient is not in a stage to understand all those, it has to be explained to the guardian or the relatives of the patient before starting the treatment. And this treatment includes a model. Treatment is based on a model called as Prochaska and D. Clement model, So this is the first kind of model which has been intervened for de-addiction and alcohol dependency. So that has been modified currently based upon the necessity. So that provides means when we are following this model, so we can gain more informations about the patients and his surroundings and relatives and his physical and so psychosocial issues and everything. So this model allows us to get um, the patient to monitor to the to find the patient's conditions, to recognize the patterns of the situations, whether the patient is in very high risk, whether he has to be treated immediately or hospitalized or whatever, or whether the patient can take the treatment as an outpatient, so which can be means if, in case if the patient is cooperating. So everything comes under this Prochaska and declement model. So the strategies which are used in this model will help us to overcome to overcome the patient's feelings or any other emotion state like any anxiety or depressions, so that he can come out of the addiction. So when it comes to the modified form of the uh, this model, modified form of this Prochaska and declement model. So the first step is to analyze the whether the other people in the family, means family members, or in case if any other, if the patient is a social worker, everybody, whether they all know about the patient's addiction, except the patient. So that is the first stage where all the other people are aware of the problem, but the patient is not aware of the problem. Means that is called as pre-contemplation, where the family members know that this is an addictive, but the patient is not aware, or whether he is ignoring uh, the situation that he will become addictive for this in very in near future. So next stage is the contemplation, where the patient recognizes that he is in addictive state and he don't know how to handle it. So that is the second stage of this model, uh, contemplation, and he needs some help either from the family side or from the doctor side to get rid of it, or how to stop it. So next stage is action, means the patient understands the consequences about this alcoholism or drug abuse, and he's ready to change. Means he is ready to come out of this addiction by changing the pattern of the drug abuse. And I hope you all know that if a patient is an addictive of the alcohol or drug, that they cannot be stopped immediately because their body won't cooperate for that. So it has to be slowly stopped. So for that, we have to change the pattern of the alcohol use or the drug abuse initially, and slowly that should be narrowed down so that the patient can stop it completely. So that comes under the last stage, maintenance, where the patient comes to know about the personal and official losses when he is continuously using the drug or alcohol, and how to and he will be aware of the strategies how to stop that drug use, so that he should completely come out of that addictive stage. Like to maintain the abstinence, means 100% no use of drugs will be there. So that is called as maintenance state or maintenance phase, where 100 the patient is 100% aware that if he gets into that de-addiction again, he may lose his um, socio-economical respect from the society or from the family side, and his future life, and so that he's ready to narrow it down to 0% usage of drug or alcohol. So, after analyzing this stages, mm, the drug usage should be completely stopped, but it should not be suddenly stopped. It has to be slowly reduced down, and then it must be ceased. So that should be encouraged to the patient. Means a doctor or any family member should never encourage the patient to take the alcohol or the drug in a very small amount throughout his life. So when we are getting into this de-addictive phase or the rehabilitation phase, the patient should be always encouraged to stop the drug at one stage. Maybe it may done slowly, but at one stage he should completely stop that. So that will be giving his means we have to explain about this losses of using the continuous usage of the drugs, and that should be achieved. So next, the quantity and frequency of drug use and the cutoff level consumption should be negotiated with the patient. So if the patient is highly addictive, so they won't accept to stop the drug immediately, and they will demand for uh, to increase the frequency of the drug usage for few days or weeks or months. So that has to be negotiated or discussed with the patient, so that the amount of the drug or the amount of the alcohol what the patient is usually taking now should be slowly reduced, and at one stage it should be 100% cut off. So that time duration and the quantity and the frequency duration should be discussed with the patient himself or herself, so that they will be cooperating with the doctors completely. So, and just in case if the patient is not ready to cooperate with the patient, or if it is very difficult for him to cooperate, is even though mentally he is ready to get into the de-addictive program, but he is unable to follow it with that. Um, and another change of the pattern should be identified and analyzed, means that he has to get admitted into any rehabilitation centers, where he will come across many other kind of treatments also, and the ways to stop this usage of drugs are all some. So this de-addiction may be done as an outpatient or by an inpatient service. So only in worst case scenarios, like very worst level of de-addiction and drug abuse, will be admitted into the rehabilitation centers, where when the patient was unable to control himself or herself um, from this cessation of this drug or alcohol. So next is detoxification. So detoxification is nothing but this. It's an means removal of this addiction. That is really very difficult for the patient, and they used to get a lot of withdrawal symptoms. So that will make them again to get into the addictive states. So this withdrawal symptoms will be unpleasant, and it will be very difficult for the patient to follow because of the mood swings, and only if when in the conscious state, if the patient is ready to undergo this de-addictive state, means rehabilitation stage, but when after starting the de-addictive program, he may not able to follow it because of his mood swings or mood change. So that's why we are going into some durations, means like any protocols or schedules to slowly cut down the usage of alcohol or any drug abuse. So when we come under, when we are about to discuss about different kinds of drug usage, each and every drug, means narcotic drugs or any other drugs which will be causing addictions, will have some different effects in the body, like to show the withdrawal syndrome in the patients. So when we see about this opioids. When the patient is an opioid addictive, so when we stop using the opioids, so the onset of time for their withdrawal symptoms will be usually from 4 to 6 hours if they are using short acting opioids. Means like when they will be giving the effects immediately, like morphine, pethidine, or heroin. If the patient is using such kind of short acting opioids, after stopping them, they will start having their withdrawal symptoms within 4 to 6 hours itself, and which may even last about to 5 to 10 days. So in this stage, so means if the withdrawal symptom starts from the 4 hours, and if it is lasting for up to 10 days, this 10 days time period is very difficult for the patient, and where again he may get into the addictive stage again. So that's why we are reducing the frequency and the quantity of the drug usage slowly, so that the body and mind of the patient will be coping up to slowly cease this usage. So when it comes to this long-acting opioids such as methadone, so this onset of the withdrawal symptoms will be from 2 to 2.5 days, and it can last up to 3 to 4 weeks. But this opioid methadone has a special usage that for the substitutional therapy of the drug abuse. Means instead of when the even when and the patient is using some other drugs. mm, when they are trying to stop the usage of that drugs, this methadone can be given as a substitutional drug therapy. So that's why they will have the onset of the withdrawal syndrome will be very late, like 2 to 2.5 days. So that will be easy for the patient to face the withdrawal symptoms, and he can come out of it very slowly. So next, when you come to the withdrawal syndromes of opioids, so that may cause some agitation in the psychomotor activity of the patients, and they may have hot or cold flashes in their skin, and heartbeats. There may be change in the heartbeats or breathing frequencies like tachypnea, and lacrimation means tears, and rhinorrhea like cold or means a running nose, or they may get even muscle twitching or spasms or muscle pains, uh, bone or pains in bones and joints. So any kind of withdrawal syndrome can be seen in a patient who is undergoing this rehabilitation programs. So, if the patient is an addictive of benzodiazepine drugs, so after stopping those drugs, the symptoms of this benzodiazepine withdrawal are again the psychomotor agitations, a lot of sweating and insomnia and disturbed sleeps along with tremors. And the onset of this kind of withdrawal syndromes of benzodiazepine will start from 1 day to fifth day, and it may be even effectively, it may be even uh, seen until 6 weeks of the 6 weeks for the patient. So next is alcohol addiction. So next, when you go to this alcohol addiction, so alcohol, when the patient stops using alcohol within 12 hours to 48 hours, he will start getting the withdrawal syndromes like sweating, seizures or insomnia or tremors in his hands or in his or her hands, and it may even this duration of this withdrawal syndrome will be there up to even 10 days. So after 10 days maybe the symptoms will slowly reduce, and the patient may even stop if he is mentally strong. So when it comes to central nervous system stimulants, so the withdrawal symptoms of the CNS stimulants causes social withdrawal, means they won't mingle with the others in the society. They want to be alone, and they will lose confidence, they'll feel fatigue and they will feel more hungry, and they may get even delusions or hallucinations, like imaginations of somebody is talking to them, or somebody is instructing them, and laziness. So such kind of symptoms can be seen when the patient is withdrawing his CNS drug. So this may start from 4 to 8 hours, and it may even seen up to 7 days for a patient. It's this. So next, coming to nicotine. So this is also very common kind of addiction, smoking. So that is nothing but nicotine, which we know. So it was even active and passive kind of addiction is there in our society. So active is nothing but if the patient he himself or herself is smoking, and passive smoking is nothing but if the other person who is inhaling the smoke of the cigarette, when the other person next to themselves, himself or herself is smoking. So more than active smoking, this passive smoking is really dangerous, and that may even cause even cancer for the person who is inhaling this passive smoke from the smoking person. So the rehabilitation means, or the de-addiction program of nicotine was actually that was very slow for in almost all the patients, because it was most of the patients they have tried to stop smoking numerous times, but they are unsuccessful. It is very difficult for them to stop this kind of addiction when it comes to nicotine specifically. So, when the patient is willing to go for de-addiction of this nicotine, they should be assisted with some any strategies of any plan to stop smoking, like they can be replaced with any nicotine gums or any other transdermal nicotine patches. So that may stop the patient to go for to have the feel for having a smoke. So, or else we have to analyze the situations. If the patient is working under any stressful or any pressureful working atmosphere, that may even also cause the patient to go for smoking. So that kind of situation also can be altered or changed or even stopped, so that the patient will stop this nicotine usage. So, when a patient is trying to stop this nicotine, the withdrawal symptoms also means, like withdrawal symptoms which will be there for the patient is like we have to go for using some any other eatables which they may like, and they can go for a distraction when the craving for nicotine is more, and they themselves can start writing a journal regarding when they feel when they want to when they get a feel to smoke, or the situation which is triggering their smoking, and so that they can avoid such situations, and they can distract themselves from that kind of situation to go into some other work, or they may move from some that kind of place, so that they can avoid that, and even they themselves can go for delaying of taking that such kind of smoking. Like if a patient is feeling an very urgent symptom of taking of nicotine, and they may delay that or postpone that for a half an hour or 1 hour, or any other in more period of time, so that it can be delayed and even it can be stopped for going for this addictive program. So next is alcohol. So this alcohol detoxification can be done as an inpatient, as an or an outpatient treatment, kind of treatment with or without any medications. So if the patient is in a good physical condition, means he is not in very worse stage of addiction, and if he's aware of all the consequences and if he's ready to go for withdrawal of alcohol, so that can be done as an outpatient follow or outpatient therapy, so that they can stop using this alcohol. And his situations, I mean, his working atmosphere and family atmosphere um, should be good, so that they will encourage the patient to stop this kind of addiction. And even if he's having getting a feeling of or craving, if he is having a crave for alcohol, that situation can be stopped or it can be postponed by his friends and relatives. So he must be in such kind of, he should be in touch with such kind of friends even in his working atmosphere. And if there is no history of suicidal ideation or attempts also, the patient can be allowed to take treatment in sorry, patient can be allowed to take the treatment as an outpatient therapy. And usually, the benzodiazepine, like diazepam, can be used as an alternative therapy or substitution therapy for an alcohol addict patient to treat their withdrawal symptoms. Means whenever the feeling, whenever the patient is getting any urge to have the alcohol, that can be at that situation he can be given any benzodiazepines, long-acting benzodiazepines, so that they can avoid the intake of alcohols. So, next is withdrawal symptoms. So just now we saw that this benzodiazepines like diazepam can be taken as a substitution therapy for withdrawal symptom of alcohol. This loading dose means initially the patient can be given 20 milligrams of diazepam for every 4 to 8 hours, so that they may not get the feeling of having alcohol inside them. Uh, and for this can be done for first 48 hours, means within 2 days they can have this diazepam dosage form. So when the dosage form of diazepam is less like 5 milligrams, so that can be taken for every 4 hours. And if the dosage form is like if he is a severe addict, then we have to go for higher dosage form of diazepam like 20 milligrams, so that may even act up to 8 hours. Every 8 hours he has to take it, so that he can avoid intake of alcohol. And this dosage of benzodiazepam or benzodiazepine or diazepam can be should be narrowed down to zero within next to 5 to 7 days. Means once if a patient stops taking this alcohol, and to avoid this withdrawal syndrome, he can be given this diazepam, and that is also for only up to next 7 days maximum. So after the 7 days, even this diazepam treatment also should be narrowed down to zero, and we have to give and give some other supplements like thiamine supplements also, so that that also will change the mental status and craving feelings, change the craving feelings of the patient, so that to avoid this alcohol intake. And during this de-addictive self-de-addictive program, or if the de-addictive program in any other rehabilitation center, every day the patient's orientation means their cognitive and behavioral therapy should be analyzed, their mental status and the fluid states in the body, like all the other lab tests also should be done regularly, and it should be assessed to analyze whether his body is ready to cope up for continuing the de-addictive program. So next, coming to this benzodiazepines. So usually diazepam is given as a substitution therapy for avoiding the withdrawal syndromes of any other like alcohol syndromes also, or any other drug abuse also. And when the patient he himself is benzodiazepam addictive, Then we have to avoid the withdrawal syndrome. We have to use the diazepam, maximum up to 10 milligrams, so that will replace the other benzodiazepines like alprazolam, lorazepam, nitrazepam, chlordiazepoxide, and oxypam, and the flunitrazepam. So all these benzodiazepines, which is addictive, when we are stopping a patient to use all these drugs, we can use diazepam as a substitution therapy drug. So maximum that can be given 10 milligram, which will be equivalent to this kind of other benzodiazepine drugs. So and that can be taken as a daily dose instead of this abused drug, up to maximum up to 1 to 2 weeks. So after 2 weeks, the dose should be reduced up to 1 to 2.5 milligrams. So initially, the diazepam can be taken for 10 milligrams, but after 1 or 2 weeks, the dose should be reduced 1 to 2.5 milligram only. That also per week, not daily, and finally it has to be reduced 100%. So next is opiates. So when you go for opiate withdrawal syndromes. So that is usually the symptoms. Withdrawal symptoms are little bit less severe than that of like alcohol withdrawal or benzodiazepine withdrawal symptoms, and this can be done as an outpatient or inpatient management also. But mostly this opioid detoxification is less successful in outpatient therapy than the inpatient therapy. Means it's better to admit a patient in any rehabilitation center for treating them, and to avoid the withdrawal syndrome or to handle the withdrawal symptoms, the patient can be given clonidine maximum up to 300 milligrams for every 6 hours, and even diazepam can be given, and slowly it has to be reduced. So this usage of this any other substitutional drugs can be given until the patient feels physically healthier, and the patient should not get any feeling of taking the drug again. So unless that moment, the patient should be followed up regularly in whether if he is an inpatient or if he is an outpatient. So mostly when the patient is seeking any other agencies like Alcoholic Anonymous or Narcotic Anonymous or Smokers Anonymous agencies, this kind of strategies will be followed up with the patient, uh, for the patient to help himself, and there will be some set of groups, patients where they can discuss about their situation, so that may avoid intake of such kind of drugs, and maximum up to 7 to 10 days the drugs should be slowly reduced, and it will be reduced into 0 milligrams. And when the patient is trying to reduce the drugs like morphine, heroin, or any other psychotic drugs, this strategies are more helpful for them. And the substitution therapy includes methadone. So that is very commonly used substitutional drug for treating withdrawal syndromes other than the diazepam, like diazepams. So we can go for methadone. So while we are maximum using this methadone for as a substitutional drug therapy is, um, so if a patient is using if the patient is using any other heroin or any other opiates, so this methadone cannot be used as an substitution therapy, because um, this this may this may not cause any tranquilizing effect similar to that of this heroin, so we can't use as a substitute for heroin. We can't use methadone as a substitute for heroin. And if the patient wants to stop using these opiates, then this methadone should not be used together along with any other opiates. Means this drug should be given as a single drug treatment. It should not be given in any other combination way of treatment. And if the patient is using more than 0.25 grams daily, 25 grams of heroin daily, then this patient can be given methadone in very small amounts, so that in very small amounts, so that they will not be dependent on this heroin anymore, and slowly they can come out of it. And if the patient is pregnant, then we can't give any other substitution drugs. So because even the substitution drugs are behaving like an drug abused drugs characters, so that may even cause any other risk for the both mother and the fetus. So mostly, if the patient is pregnant, when they are, if the patient is found pregnant when they are using this drugs, mostly the babies, either they will be they'll be having some other congenital problems while birth, like any other default in organs, or in growth of organs, or a default in any other growth of bones, or hands or legs, and some other side effects also will be there. We can't use any other substitution therapy also for patient who is pregnant. So this kind of methadone detoxification will be offered by only the trained and licensed practitioners. Means only doctors can get involved exclusively when they are trained for this rehabilitation program. They can use this replacement detoxification by using either diazepam or methadone like this. And based upon the usage of abused drug and the quantity of the abused drug the patient is having, the doctor or the practitioner has to calculate how much amount of methadone can be given to the patient to avoid this withdrawal symptoms. Also, we can't since we can't give more amount of this substitutional drug like methadone or diazepam also, so that may also even cause euphoric effects in the patient. So we can't give more amount. So it has to be carefully analyzed by the practitioner how much amount of the methadone or diazepam can be given for avoiding this withdrawal symptoms. So after almost 6 to 12 months of stabilization, the patient is allowed to, means our patient is encouraged to work by getting into a new lifestyle. Means after this 6 to 12 months, almost it is believed that the patient will not get into this kind of addictives anymore, and they will be more mentally stable to avoid such kind of addictions. And 100% this dose of methadone can be completely reduced or stopped in 1 or 2 years. And these substitutional drugs can be means collected, means the substitutional drugs can be taken by the patient from the drugs on a daily basis. Means daily they have to contact the practitioner or the doctors to take the daily use. It should not be given on a prescription basis. Means they won't give them in a bulk amount, so that it may encourage the patient to take in more amount. That is the reason. So next, while the patient is in this rehabilitation or de-addictive programs, their urine test or any other blood test should be analyzed continuously to find whether the patient is taking any other drugs unknowingly or knowingly, and to avoid that the side effects of this substitutional drug or any other normal drug which is prescribed by the patient. So we have to check this laboratory test daily or once in a while in a week to avoid those issues. So the last topic is the principles of management of substance abuse disorders. Means when after when the patient is coming out of this de-addictives, means addictions, after this de-addiction or rehabilitation program, so the lifestyle of the patient should be carefully monitored so that again he or she will not become any addictive. So we have to establish a very good working atmosphere and very good relationship in this family, so that the patient will not get into the addiction again. So the patient should be explained about the losses, what he will be facing if he becomes addictive again, and what will be the effect of the relationships between the family or in the official way, and affordability means the financial issues. Everything should be explained to the patient, so that he will never get into the addictions again, so that he will be mentally strong. So next is to establish the environment of safety. So he has to mean some strategies should be discussed with the patient, so that to achieve this kind of safety environment for the patient. Means some goals should be uh, placed for the patient, so that he can attain that goals, and he'll feel happy to continue that kind of situation and again and again. So these goals must be very simple, and it should be in short time period, so that the patient can easily attain the goals without any reinforcement, means without anybody's force from the other third persons, so that he will be getting come out, means he will have the mental stability to come out of the addictive programs again. And he has to be means taught about how to stop the substance abuse, like even if he come across that kind of drugs in the near future, and if he fails to follow that once in a while, means because of any cravings, or if because of any social relationships, just in case if he tries the abused drug again in between. So that can be dealt with the patient, saying that failing is common, like relapse is common once in a while, and it should not be continued anymore. And that kind of we have to deal with the patient with few strategies to avoid such kind of situations. And his lifestyle losses should be discussed, so that what kind of respect will he'll be getting, just in case if he is getting into addictions again. And he has to attend, he has to be in touch with some self-help groups, means with the persons, some other persons who are also um, in this rehabilitation program. So when the patient is in touch with such kind of other persons, it will be more encouraging for all of them, and to analyze the situations, how to avoid addiction again, or how to avoid any other abused drugs again. So that will also be more encouraging for the patient to avoid this. So thank you. And this is about alcoholism and drug dependency. Hope you guys understood. So I just want to give you a 5 minutes break, so that next we can start with the setting up of this de-addiction and rehabilitation centers, how the centers must be. So I'll be back in just 5 minutes. Hello. I hope you guys can hear me. So we'll continue with de-addiction and rehabilitation centers now. So we have seen about this alcohol and drug dependency so far, and what all the drugs will be causing this alcohol and drug dependency, and what are the issues or withdrawal syndromes with different kind of these drugs be causing others. So now we will see about this setting up of this de-addiction or rehabilitation centers, uh, which agencies or which ministries undertaking all this rehabilitation centers and how the centers should be. So de-addiction is nothing but curing the addiction. So it is an treatment for the addicts. It may be because of any other drug abuse or alcohol abuse or any nicotine abuse or whatever. So this is mainly done to avoid this physiological effects of these addictive substances. Means these addictive substances may cause some issues in our physiology means anatomy and physiology of our means normal functioning of our organs or muscles or tissues. So these addictive substances will cause some effects in this normal functioning of our tissues or organs. So that in order to avoid those effects, we need to make the patient to undergo this de-addictions. So this also will be neutralizing the toxic properties, so which will be usually affect the normal functioning of our body. So this toxic properties means when a drug is getting accumulates more and more into the body, so that will cause this toxic effects. So that will be usually very difficult for a patient to face it, and they may even cause some inability of the organs to do their own work, and it that may even usually fatal when it comes to this drug abuse and alcohol abuse. That will slowly stop that will be slowly that will be slowing down the functioning of our organs, main organs like kidney or heart or liver or lungs or whatever may be, so that the patient ultimately in the final stage that will cause lethal effect to the patient. So this centers, this de-addiction and rehabilitation centers are made uh, to stop this addiction or to stop using of this intake of drugs by the patients, and to give them a healthy lifestyle. So which they may not think about it after getting into the addiction. So we have to, these centers will be uh, treating the patient to come out of all these physiological effects and the toxic properties, and they will be encouraging the patient to get into the drug-free life, which will be more healthy and happier for them. So, so that is the purpose of this de-addiction centers, and this is initiated by our Indian government in several ways. So, first of all, three broad approaches are followed by this, followed by our Indian government to handle this drug abuse. So, first one is supply reduction, next is demand reduction, and harm reduction. So supply reduction is nothing but totally to stop the supply of this kind of usage of drugs. So this the drugs which are causing this addictions or abuse has to be completely decreased. The availability should be decreased. Mostly, if we see, for example, when we go for this antidepressives, so that is they are kind of sedative drugs which are used for common cold and cough. So that actually those antidepressives are treated for this cold and cough, but they have this kind of effects like addictive effects or this euphoric or any mental peace causing kind of stage. So they have those drugs will be giving such kind of effects also. So, but um, our government has approved such kind of drugs for the treatment of some other disease, but they have been misused. They have been abused to get into addictions. So we have to replace that kind of drugs with some other drugs which may not cause addictions. So that is the supply reduction means where these laws will be slowly decreasing the availability of these addictive drugs even for the treatment of some other disease, so that when the supply is totally stopped, obviously there will be minimal usage and the addictive issues will be minimalized. So this kind of supply reduction is followed up by some central and state government agencies, and even the Indian government has formed a national policy on this narcotic drugs and psychotropic drugs. Mostly, this narcotic and psychotropic drugs are used for some psychotic diseases, but these patients are using is for addictive purposes. So they have formed some separate rules and regulations for the availability of such kind of drugs. So next one is demand reduction. So like um, the first one we saw is like supply reduction. So next one is demand reduction. Supply is totally to stop usage of those drugs for because of addiction. We are stopping the usage of drugs for other diseases also. But when it comes to demand reduction, so we have to this interventions like this intervention is mainly aimed for this prevention, treatment, and rehabilitation. Means that kind of diseases means the abused drugs are used for certain kind of diseases. So we are trying to prevent that kind of diseases so that there will be no demand for these drugs. So there will be no need of treatment, and there will be no need of addiction, and there will be no need of rehabilitation. So this kind of demand reduction is implemented by two ministries. So, Ministry of Social Justice and Empowerment, and the Ministry of Health and Family Welfare. So, these two ministries are actively involved in this kind of demand reductions, and they have implemented several schemes, policies, and programs in order to prevent this substance abuse and alcoholism. Also, this ministries, they focus on training the associated health workers. Means if there is a de-addiction center or if there is a rehabilitation center, obviously there will be some health workers. So they have to be trained accordingly in order to handle this patients, the addictive patients. So where the patients will be having some lot of withdrawal syndromes or symptoms. So these workers should handle such kind of patients, so that to help the patients to come out of this addiction. So these health workers are specially trained by these ministries, so that they will be always there will be availability of such kind of persons in the centers. So the last one is harm reduction. So first is supply reduction, next demand reduction, this harm reduction. So this harm reduction is related with the infections, to avoid the infections or which is associated with kind of with the addictions. For example, if the patient is taking any morphine or codeine in a parenteral way, means like in injectable way, obviously there will be usage of this injections in the patients, so which may cause any other cross infections like immunodeficiency, viral infections, or hepatitis, even HIVs. So such kind of diseases are being spread because of usage of injections where patients are using this kind of drugs. So we have to. This ministry is responsible to reduce such kind of spreading of such kind of infections, also like HIV or any other immunodeficiency viral infections or hepatitis. So this harm reduction is focused on that side effect, such diseases which are the side effect of the drug abuse. So many strategies are being followed or and created in order to avoid this. For example, when you go for this opioid substitution treatment. So that is provided to the injectable drug abuse patients, so that there will be no usage of any injections anymore, and that will be controlled. Means this immunodeficiency or any viral disease can be controlled. So next is management of drug addiction. So, uh, in the last hour, we saw about the what are the withdrawal syndromes and which kind of drugs are being used for addictions, and we saw that there must be some treatment. There's some de-addiction treatment or any rehabilitation treatment must be there for addiction. But now we are going to see about what kind of treatment should be given for such addictive cases. So, first of all, the drugs which are causing these addictions, drug addictions, are mainly central nervous stimulants, central nervous system depressants, and stimulants. So they are more addictive when compared to that of other abused drugs. So this can be managed. This kind of drug addiction is managed mainly by three kind of therapies. So where pharmacotherapy, behavioral therapy, and social support. So these are the first three steps of management of drug addiction. So this will be followed by some physical treatments or mental, social, and vocational rehabilitation. Vocational means continuous follow-up and counseling and discussion with the patient when they are undergoing this de-addictive program. So that will be followed.
Ma'am, sorry to interrupt, ma'am. Ma'am,
Yes.
ma'am, you were telling about
Yes.
supply reduction, harm reduction, ma'am. One more reduction, ma'am. Slides are not changing for me, ma'am. Slides are presented, ma'am.
Yes. Okay. I
Supply
will stop it
reduction,
and
harm reduction.
yeah, I will stop it and again I will share the.
Sure,
Video
ma'am.
message.
Yeah,
Sorry to
thank you.
interrupt, ma'am.
No, it's okay, ma'am.
Okay, ma'am.
I hope you can see this now, ma'am. Ma'am, can you see this slide now?
Ma'am, not yet, ma'am. Shall I rejoin? Shall I have to come out and rejoin, ma'am? Not yet. I got the screen, ma'am.
Maybe you have facing some network issue. Better to rejoin.
Sure.
Okay.
Okay,
Is
brother.
everybody is
Ma'am,
facing this issue or I don't
No,
know?
no, only for her. We are
Okay.
getting all slides.
Oh,
okay,
okay,
ma'am. Please
ma'am. Then
continue,
you
ma'am.
kindly
Ma'am,
rejoin.
please
You
continue.
can
Yes,
rejoin.
ma'am. Sure, ma'am.
Thank you. So we are talking about this management of this drug addictions, where we can see this pharmacotherapy and behavioral therapy and social support, followed by all the other kind of social, physical, and mental treatments along with this occasional treatments. So when it comes to this pharmacological treatment, like interventions, that is the foremost treatment which has to be done for a de-addictive person. So stopping detoxification means stopping of intaking of such kind of abusive drug is the first step. So which may cause some withdrawal symptoms. So in order to avoid or to handle or to face this withdrawal symptoms, we need to facilitate the patient along with some other drugs. What we saw is before like methadone or diazepams. So these drugs are FDA approved usually. I hope FDA, this Food and Drug Administration Agency in US. So they have approved some antagonist to avoid this kind of overdose of addictive drugs, and they have even approved this. substitutional drugs for this withdrawal syndromes. So these substitution therapy is a very common therapy which is being undergone by these addictive patients. So that these drugs will be acting through the same receptor for the patient, but they won't give the side effects of the abused drug for a little period of time. So that is also only for very less time period. So that the patient should come out of such kind of cravings and everything. So that is the first pharmacological intervention of the drug addiction. So next is cognitive behavioral therapy. So the patient should be taught about the behavior or any dysfunctional thoughts, and it has to be discussed about to the patient, so that they may means how pathetic their situation will be when they are when their condition is becoming very worse, when they are continuously using this abused drugs. So they should be explained about all the merits and demerits of this drug use, and so that how they will be going for wrong, misusing any wrong decisions, which will be affecting their health as well as their life of others, means their family. So these behavioral strategies are developed mainly to avoid these cravings. So whenever a patient is feeling the craving to take for any alcohol or any other drug, when they have to analyze about these kind of situations, cognitive behavioral therapy situations, so that they themselves can control to avoid this kind of addictions in related to with family or any social status. So this kind of therapy can be given face to face, means the patient is requested to come directly to the de-addiction or the rehabilitation center to explain or discuss about or analyze about these issues. Or else it may be, as the technology is improved now, it is even computer assisted now. So they can, even the patient can undergo this computer assisted therapy, where they may discuss with the doctor about their issues and to solve how to solve them. So next is motivational interviewing. So in this method, the patient is motivated to change the patterns of the drug abuse, so that they will be slowly reducing it. So we have to means the doctors have to talk more about the positive outcomes of the de-addiction program, so that the patient will be will be ready to happily accept that kind of de-addictive programs. And this method is incorporated with based upon few principles, such as empathy by the counselor, means first of all the doctor should understand the situation of the patient, where the patient is undergoing this kind of addiction of the drugs, means at what situation he chose these drugs to take continuously. So that atmosphere, working or family atmosphere, or any legal issues or any financial issues, that has to be analyzed by the uh, counselor, and it has to be discussed with the patient to avoid such situations, means how to get rid of them. So next is self efficacy, where the patient, he has to understand that even though many others are helping, it is only the it's only himself or herself who has to undergo all those changes, and they have to be stubborn in order to avoid these addictive drugs, and they have to carry out, means they have to avoid those such kind of activities to change themselves. So next is rolling with assistance. So means the patient should be not feel to confront in front of the counselor, means they should not avoid anything to discuss with the counselor. So only with the help of assistance with the counselor, the patient can easily come out of it. So that is the next step. So next one is developing this discrepancy. So where the after knowing the situations or any new issues which is being faced by the patient when they are undergoing this de-addictive program, the counselor should help the patient to avoid such kind of situations, and they have to focus on their future healthy lifestyle or any other socio-economic lifestyle, so that they have to overcome the current situation. So this motivational interviewing is mostly very helpful for the patient. Means whenever they have some issue or craving when getting to the addiction again, they have to immediately discuss with their counselors or the doctors, so that they can come out of that situation immediately. So that is a kind of treatment. So next is contingency management, means eventuality management, where we have to make the patient to come to the therapy continuously, and that continuous attendance should be um, encouraged to the patient in terms of incentives, means like giving some um, personal or any official incentives, so that they will be continuously coming for treatment, and they will be avoiding the usage of these drugs. So next is occupational therapy. So this is an it's a part of rehabilitation process, means which will help them to come out of this addiction. After coming out of this addiction, when they are getting involved in any other works based upon their skills, totally they will try to forget about this addictive drugs. So that is actually occupational therapy, where we have to find the skills of the patients. Means like individually what kind of what kind of skill the patient is having, what they are interested of. So we have to make the patient to get involved into that, and so that the person will be involved, the patient will be involved into the work completely, so that they may completely avoid this addiction or any other drug use. So next is physical therapy treatment, means when the patient is long-term use of any drugs or alcohol, obviously their physical condition will be very weak, and these muscles and tissues will not be in normal condition. So in order to help the patient to lead a healthy lifestyle, this physical treatments like exercises or any other programs should be done, so that they'll feel more healthy to get involved in other healthy lifestyle. So this also should be done, means or supported or encouraged by the any counselors or any doctors to coordinate along with the exercises, and in just in case if they are having any hot or cold flashes or mood swings, how to handle. So everything should be taught to the patient to avoid those addiction again. So next is about centers like de-addiction and rehabilitation centers. So these centers are established by the government of India from 1985. Currently, there are about 122 drug dependence treatment centers, means rehabilitation centers in India, and this was taken care by the ministries, two ministries, as I said before, Ministry of Health and Family Welfare, and Ministry of Social Justice and Empowerment. So these two ministries are highly involved in this prevention of this addiction and treatment of this addictions or substance abuse from 1985. So this, apart from these two ministries, many agencies or societies like NGOs are also working along with these ministries to avoid this addictions, and the Society of Promotion of Youth and Masses. So this is the first NGO, Indian NGO, working throughout our country. So the main motto of this NGO is about drug abuse prevention and treatment and rehabilitation, and to avoid this other comorbid disease like HIV and AIDS, and even tuberculosis or hepatitis or whatever comorbid disease. So everything is focused by this NGO. And first rehabilitation center was opened in North India in 1985. So that was done by this NGO, Society of Promotion of Youth and Masses, and it around several thousands of people have been benefited by this NGO, and successfully they are leading their life after attending this kind of rehabilitation programs. So this NGO provides not only the treatment, also for prevention of availability of the kind of abused drugs in our country, and they even provide treatment services for young adolescents and juveniles, means below 18, and kids like children's, if they are also addictives, and this is the only NGO who are treating the persons below 18. So next is Narcotic Control Bureau. So this Narcotic Control Bureau is mainly enforced for control the availability of narcotic drugs, or like illegal drugs, means which are being in the market without the permission of government. And this illegal drug act was very strict, so that even these drugs can't be prescribed by the doctors that easily, and this can't be even dispensed in the pharmacy without a prescription. And even if it is prescribed, it must be in very low doses, means a bulk amount of drugs will not be prescribed for the patient. The patient has to collect the drug in a daily dose, or the patient has to intake the drug in front of doctors or any other counselors or any other pharmacist, so that they can't store the drugs for more time, and they can't use it for addiction. And this kind of drugs come under usually under Schedule H drugs, so which is very strict. The scheduled drugs will not be available that easily for common society members unless until a doctor prescribes this. So this Narcotic Control Bureau, it performs its activities throughout our country in the basis of zones and subzones. So mostly all the uh, state capitals works as a zone head for this Narcotic Control Bureau, and the subzones will be somewhere inside the state where that can collect all the informations, and it will be passed on to the zones. So mostly subzones will be available, means subzones will be there almost in the center of the state, so that it can work more efficiently to know to collect more informations or gather more informations about this illegal drug movement and trafficking. So next objective of this programs like centers, like rehabilitation center is nothing but first preventive education. So how to avoid this drugs, means these addictive drugs are when we closely monitor the history of these patients, most of the patients would have got into this addiction only by trying it just like that for the first time, or like by supplied by their friends, or like social activities for fun, something like that. So in order to get into this addiction, first of all, this generation must first be taught to avoid or prevent this kind of drugs. So that is the first and foremost objective, where uh, the person means it has to be the persons are taught not to even try it once for any other social fun activities, because of any social fun activities. Next is identification of the substance dependent persons for motivational counseling. Means most of the addictive persons who are involved in this abusing these drugs say they won't expose themselves because they know the fact that the society will not allow them to continue. So at one stage, at the first and initial stage, they will avoid saying that they are using such kind of abused drugs. So in later stage, they won't mind even if the society is criticizing about it. So the person, if they are in initial stage, if we are identifying a patient who is in the initial stage, it will be easy for us to counsel them and to motivate them. So that is the second objective of the center. So next is detoxification and whole person recovery. So this is the major one where when we found a patient who is in a very worst stage of this addiction, so he has to be admitted in any anti-addictive or rehabilitation center, and the person is completely. We try to recover the patient completely, mental wise and health wise, so that he can lead a happy and healthy life. So next is referential services. So referral services means if based upon the drug what the patient is using, and when we are going for any substitution therapy or any cognitive or behavioral therapy. So that can be referred to the nearby zones or subzones where it is well treated, and it can be and the patient can be completely recovered. So next one is aftercare and follow up. So it is not only means treating and completely recovering the patient is the duty of the rehabilitation center. So even after the complete recovery, and the patient should be followed up by these centers now and then in from frequent intervals to check whether they are still like means currently they are not following any other addictive drugs, so that has to be followed up. So next is care and support for families for codependence. Means because of this drug abuse and addiction, and many of the family situations have been suffered financially. So in order to help them to come out of this financial problems, this support can be done to the families of the patients, like whether they can be allotted some work, or if they are encouraged to do some other job, or with any other educational loan, any other business loan, so that it will be helpful for the patient to not to get into the addiction, and the family will continuously following after following such kind of jobs, they will come out of the financial issues. Next is rehabilitation, that is complete only the treatment. Next is period of stay. So, according to this strategy of the centers, rehabilitation centers, the patient should be treated maximum in 90 days. Means they will try to completely recover a patient maximum in 90 days. So that the patient can lead into the normal life. And when the treatment is when the patient is undergoing the treatment, the it is a responsibility of the centers to provide a healthy food of free of charge, and the drugs which will be given to the patient, like any other substitutional drugs or any other drugs for the treatment, everything should be free of charge, and that it is responsibility of this rehabilitation center. So when it comes to the staffs and officials who are associated with this integrated rehabilitation center, so this is an approximate and overall officials list which will be normally available in any rehabilitation centers, and based upon the necessity and need, the more staff can be added to the centers. So usually the project coordinator or counselor will be the chief and head. So and there will be an accountant. So in order to uh, maintain the accounts income of the center and the expenditure of the center, we need a separate accountant, and there will be a cook to give an healthy food to the patients, security guards to handle the mentally depressed or any worse conditions of patients, and nurses, ward boys will be there, and counselors and social workers. So counselors will be there for both. They'll be working for both inpatient and outpatient, and the social workers, even they will be into the society to find such kind of any drug addicts and counsel them to get into the rehabilitation center for treatment, and yoga therapists will be there. So in order to teach the patients to come out of this kind of addiction and to avoid the mood swings, and the peer educator will be there in order to teach the value of the life and their behavioral changes and everything. So mostly the addictives in the first stage of their addiction, they totally ignore about the criticizations of the other society members. So that values means society value or this social value of the persons should be again taught to the patient so that they can live a worthy life in their future. So, in the rehabilitation centers, mainly we have these three departments: outpatient, inpatient area, and administrative areas. So, outpatient area means not all the patients will be getting admitted into the rehabilitation centers. A few patients who are mentally strong, or if they are in initial stage of addiction, they can visit this rehabilitation center then and there, and they can treat themselves. Only frequent consultation is necessary. So outpatient areas includes all this outpatient consultation chamber and counseling room and waiting area. Obviously, next toiletries, next pharmacy, dispensing room, registration room, and admission office, and medical records office, and storage room. And inpatient area, so they also have almost the same kind of consultation room and counseling rooms, and all the toilet rooms and registration room and store rooms, etc. Apart from that, inpatient area will be having the beds and the nursing stations for the patients, and treatment rooms for separately, and doctors room, and nurses changing room, and patients relative waiting area, and activity room and recreation rooms will be there. These are apart from the areas of the outpatient area, where here also registers will be maintained for inpatients and outpatients separately, and pharmacy will be there in common, which will be acting for both inpatient and outpatient area. And for administrative area, there will be a room for officers and accounts personnel and storeroom separately. And when it comes to the building of the rehabilitation center, preferably it should be on its own, means like not should be rented, not to be rented, to avoid unnecessary issues in the future. And the surrounding should be clean, and it should be accessible, easily accessible. It should be from the outside, and there should be a display of the center in the local language and the common language, so that anybody can identify the center easily. And this facility should have some tie-up with the local district hospitals or any health centers which will be nearby, so that if there is any need, they can access, the patient themselves can access there, only for emergency situations. Other than that, rehabilitation centers itself They themselves will have some all kind of treatment rooms and drugs in the pharmacies. But for emergency services, they should have some tie-up with the district hospitals nearby. So next is the entrance of this rehabilitation center. It should be well lighted and ventilated so that it is comfortable for all the patients and even the relatives who is coming along with the patients. And even ramp facilities should be there for disabled patients for like to move the wheelchairs and stretchers. Period of 1 year means even after 3 months, if the patient is treated completely and recovered, we have to follow up with the patient at least a minimum to 2 years. So a record should be maintained separately for outpatient as well as the inpatient with different means unique registration number means that must be easy to identify the patient immediately. So before we saw about the NGO centers will be we saw that the NGO center is having some zones and subzones throughout our country, like capitals of the state and in between subzones in between the state. So when we are collecting information from all the sites, means all the states and all the districts throughout the states. So it is very difficult to identify the patient. So the patient may migrate from one state to other state or one district to other district, but still their case history must be commonly available when you go for central levels. So in order to identify that patient, even if they are migrating from state or district, this registration number must be very much unique. Means based upon the district or the area, the registration should be will be allotted by the centers, like from NGOs, so that it will be reflected in their all the records and will be easily accessible for the patient wherever they go. So most of the hospitals have the central registration centers. So means like throughout the country they will be having one registration system, so that different state will have different codes for this registration number. Like for mentioning means to easily to identify the states and districts and the patient. So that will be easy for monitoring and evaluating. So next is waiting area. So usually number of patients who are admitted in the rehabilitation centers are limited. So that is because to easily to handle them. So too much of crowd will be difficult for the patients as well as the workers, health workers who are working there. So maximum based upon the number of patients available in the center, and as per means expecting further increase of admissions, maximum the areas will be calculated. So the waiting areas is proposed to be almost like 40 square meters, where it will be having all the basic facilities like water, entertainments, and like sorry, good ventilation and everything. Next is a doctor's chamber. So that also will be with good lighting and ventilation, where he can access access the patient with all the necessary equipments nearby, and for along with in the presence of the relatives of the patient. Next is outpatient department. So that is usually functionally a separate entity. So they won't counsel or treat both the inpatient and outpatient together. So outpatient department will be totally handled separately, and there will be separate doctors and counselors. Means working time of this inpatient and outpatient may be at least different, so that there will be no other confusion. But same doctor can work for both outpatient and inpatient department, but not at the same time. And the next one is normal toiletries, like it should be separate from male and female, and it should be different for staff and patients. And in outpatient department, it should be one should be available for even for relatives, and the styles of lavatories along with basins also, or as per, it should be built as per the strategies. So next is pharmacy. So this pharmacy in a de-addiction center is a major part, and it can work for both inpatient and for outpatient also. It may be a common one because same kind of drugs will be treated for almost all the patients, and minimum level of almiras or cupboards are limited as per the protocol for storing all the medicines, and along with the refrigerator. And this pharmacy key should have some double lock and key mechanism, because it will be having all kind of scheduled drugs, so which is really dangerous when an addictive patient is accessing it. So locking mechanism should be double lock, and it should be very careful who is handling it. Next is dispensing room. Means dispensing room is a place where the drugs are being dispersed to the patient, like customer and pharmacy personnel meeting area. Most probably it will be like in one side of a pharmacy, this dispensing room will be there, and it should be access easily. It should be accessible for all the patients, and drugs must be free of cost. So this patient can access to the dispensing room, where the drug will be dispensed by either a nurse or a pharmacist. So they themselves can't dispense their own medications. Only the authorized persons are allowed to handle and to dispense the medications. And the patients, the name of the drugs and the patients should be recorded in a separate register, and that should be supervised by any trained persons like a pharmacist. So next is administrative area and storage. So this administrative officer will be allotted a separate room, and even the accounts person will be allotted a separate room. And for the since because this finance department also will be having a lot of work in administration, so they are separate. The rooms are allotted separately so that they can maintain the accounts, and for storing this medical like pharmacy or any other drugs or any other general requirements or any linen stores, a separate storeroom should be available. And for record maintenance, since this is a chronic disease, this addiction is a chronic disease. As we discussed before, that even after the treatment, the patient should be followed up to minimum 1 to 2 years. Their record should be maintained, so there will be a need for a record maintenance room, so that we can analyze the patient's treatment episodes whenever necessary. So that's why we need separate record maintenance. So other than this, all this pharmacy or rooms or consultation room or beds or wards, the other requirements which are needed in our center is water supply, which will be 24 hours. Provisions must be there, along with the geysers to use in cold season. And next is waste management. So this we know it already, that even regular hospitals need to follow this waste management system, where they can dispose their biomedical waste in the center. Similarly, rehabilitation center also need a waste management system which is clubbed with biomedical waste management, so that they can discard all those wastage in a safer way. So next is signage and publicity, means nothing but there must be a billboards there in order to identify this rehabilitation center, so that it will be easy for the public to identify such type of hospitals. And security services, next one. So security services, they also play a serious role because some patients, they may turn into violent at times because of this withdrawal syndromes. There will be a lot of mood swings, and because of when they are in long-term usage of this illegal drug usage, so they may even try to access this drugs, addictive drugs. So at that time of outburst, we need some security services to handle those violent patients so that they won't break the wall properties. Next, furnitures. Based upon the necessity, the furnitures should be available. Means like as per the standards of Indian public health standards, uh, we need to place all the furnitures in all the rooms as per the protocol of this Indian public health standards. So next is shared services. So apart from this rehabilitation center services like pharmacy or treatment, everything. We have some shared services with the main hospital, means like nearby hospitals or main hospital of main rehabilitation hospital at times of emergencies. And when we want to analyze the samples of the patients like laboratory and or any other diagnostic services, and for kitchen dietary services, which can be in tie-up with some other places also, which will be shared from outside also, laundry services and housekeeping services. So these are all shared, not exclusively followed only for the rehabilitation. So based on the necessity, it can be shared from outside or any other hospitals. So next is motivation of the staff. So it is apart from the health workers who are working in normal hospitals, the staffs who are working in this, particularly in the rehabilitation centers, need to be so strong and motivated to continuously do service for this addictive persons. So they have to handle those patients very patiently, and they have to analyze those patients based upon their behavior in day-to-day activities. They have to analyze the patients and what kind of service they will be needing. So these staff should be trained accordingly, and this training programs are usually done by these ministries, and after that they are being selected by examination and interviews, usually in any contract basis, like minimum 1 year contract basis, they will be selected. So next is the challenges faced by the rehabilitation centers. Means not all the rehabilitation centers are working like very smoothly and fully based, because the first and biggest challenge which the rehabilitation centers are facing is the financial issues, that they are not receiving the grants in the timely manners. So they may there because of some protocol issues or any other issues, that may be the receiving this grant in particular time may be changed. So because of that, they will be facing a lot of financial burden where they have to manage that also, and chief has to face all these issues to handle the rehabilitation center. And mostly another next challenge is the number of members. Mm, Means the staff members who are working in this rehabilitation center are not having any required training programs. Means the training programs which is conducted by the ministries are not often. So because of that, they are the staffs who are working are lacking of this training, how to handle the so it means how to handle this persons, or like the addictive persons during this withdrawal syndromes, because they may, because of the mood swings or any frustration, they may use even abusive languages, or they may even hurt the other person. So that may that will be very difficult for the persons who are working in rehabilitation centers. So in order to handle them, they need a proper training, which is being lacked actually. So usually the working staff in the night time will be very less. So that is very difficult for the staff to maintain the security of the patient as well as the center. So, as per the protocol, even if the recreational activities we have, even if the center is having any room for recreational activities, so that is not continuously followed by the centers because of lack of persons who are involved in this recreational activities, or the persons who are involved in this kind of activities for making the patients to work on it. So that is another difficulty, and it is difficult for it is difficult to motivate a patient to keep a patient in the same motivational stage for de-addiction treatment. So they have to counsel the patient very frequently and oftenly by analyzing the situation of the patient. So once, if we miss to counsel a patient who is uh, craving to have the abused drug during the withdrawal symptoms, uh, if we fail to do that, obviously the patient will again become addictive. So that is difficult, and we have to analyze, and we have to follow up with the patient. So, thank you.
Thank you.
Yeah, Anita ma'am, I think you raised your hand. Do you have any doubts? Hello, Anita ma'am, do you have any doubts? I hope you have raised your hand for some reason. I have seen it now.
Ma'am, good afternoon. Is it audible, madam, now? Is it audible?
Ah, yes, yes.
Ma'am, actually, I have to take class by 12 p.m., so only I have raised. That's it. No more doubts, ma'am. Thank you.
Sorry, ma'am.
Thank
I
you,
was
madam.
waiting. Thank you.
Thank you, ma'am.
Thank
No
you.
problem.
Sorry.
Thank you so much. Thank you. Sorry for disturbing.
No problem, ma'am. Thank you. Please continue.
Thank you. Thank you, ma'am. Thank you. Good afternoon. Is it audible? Good afternoon, everyone.
Good afternoon, ma'am. Yes, ma'am. Audible.
Yes, thank you, sir. Today I'm going to cover the topics health information technology and its impact on healthcare and impact on society. Let us know the primary components of the health information technology, and it comprises like electronic health records, personal health records, electronic prescribing, nothing, it is also called as e-prescribing, and privacy and security, and then health information exchange. The health information technology, it can also be called abbreviated as a HIT, or a health IT, which is defined as the application of computers and technology in healthcare settings. So in the and again, the information can be divided into it consists of some important terms like data, information, knowledge, and wisdom. So data is a raw material what we can get, which is an unprocessed material which don't have much significance. For example, if we are writing a number 5 without any details of that numerical value, either it is 5 minutes or 5 um, meters or 5, whatever it may be, if you are not writing anything, it isn't just data. It don't have that much signification. If we are adding something else, it will have some priority, or it will be getting more meaningful. So nothing but the next is process data is called as information, and the information is a meaningful data. So the data is an raw data which don't have much meaning, and whereas information is a meaningful data or facts from which conclusions can be drawn by humans either or computers. For example, the 5 fingers. In the data, we have discussed an example of 5. Here, the 5 fingers, if it is mentioned, it uh, it is meaningful that there are 5 fingers, and modern computers do not process information; they process data only. So this is a fundamental problem and challenge in informatics. If we are writing simply 5, it don't understand, then it cannot process that raw data. So we have to give the information, and then the processed or the meaningful data, if we are observing or we are processing that meaningful data, which is so called information, we can gain some knowledge. There's nothing but information that is justifiably considered to be true. So here the raw material is raw data. Raw data is nothing but unprocessed data is data. It is called as data, and it is the singular word is datum and plural word is data, and which is finally processed, it is termed as information, and then which again if it is having a justifiably concerned, means whether it can say either true or maybe or false. If we are justifying that information, then that can be called as a knowledge, and which can have more significance than the information. And then this knowledge, if it is finely processed, then it is called as wisdom. The wisdom is the critical use of knowledge to make intelligent decisions and to work through situations of signal versus noise. See here, I want to explain these 4 terms by using a example of a disease. If we are having just running nose, it is just having a running nose. But if it is accompanied with a fever, or again throat pain, and again some more thing, and if past history, if we are adding more, and then if any medication, or if he has either vaccinated with the COVID vaccine, or if we are refining with all the data, then the doctor can give a fully or full-fledged treatment to him based upon all the data given and the information, past history, and then the knowledge based upon his experience, and then the treatment, the wisdom, by his wisdom he can give a good treatment. So in this information technology, nothing but the health information technology is defined as the application of computers and technology in healthcare settings. So thereby, this is the information hierarchy. The first, what the data will be getting from the patients or any other public or any other resources is called as raw material, is called as data, and which again further processed and which is meaningful is called as information, which can be justified, that can be called as knowledge, and through this, which is again we can more refining as a wisdom. And these are the levels of data. And in case of level 1, non-electric data, when we go to hospitals, will be in most of this, even nowadays, when we go to a hospital, we need to get a OP, which is a handwritten manner. That is nothing but non-electric data. It is nothing but paper forms. Then after going that which can be scanned. If it is having a barcode, it can be scanned, and then it can be viewable electronic data. So nothing but scans forms of paper forms. This is level 2, hierarchy level of the data. And then level 3, it is structured, viewable electronic data, electronically entered data that cannot be computed by other systems. The barcode can be scanned by that particular system only. It cannot be accessed by other computer. So this is called as a level 3. And level 4, the computable electronic data, electronically entered data that can be computed by even other systems. Is nothing but if you are entering the data based upon the mobile number with not using the scan code, IR scan code. If it is given by, if you are telling the your mobile number or any other data or by your email ID or anything, they can be accessed easily and by using your things. So level 1 is non-electric data, paper forms. Second one, unstructured viewable electronic data, scans of paper forms. Level 3, structured viewable electronic data that cannot be computed by other systems. Level 4, computable electronic data, where the data entered that can be computed by other systems even. And the health data sources includes various health data sources are like electronic health records, EHR, PHR, personal health records, home monitoring, and health information exchange, and data warehouse, claims data, and totally these all is called as health data. So these are the various sources of health data. And the information technology and healthcare functions, the information, either it can be either internal data or external data, which can be processed by using a networks or internet or health information systems or library information systems, databases. That is nothing but by using some technology we can obtain or we can produce more patient care and very fine refined medical records, ancillary services, laboratory and radiology, pharmacy services, and also administration in case of administrative like finances and business analyticals, and then some research also we can do by using this information. By adapting a technology, we can get more healthcare functions like patient care, medical records, ancillary services, laboratory, radiology, pharmacy, administrative, financial, business, and business analytics and research. So these are the healthcare functions, but which we can apply, we can derive by using the information, the data which is processed as information and the information technology. We can get all these functions. This is the significance of healthcare, health information technology. So these are the following are the examples of some of the applications programs producing health related data. The community health status indicators and the child growth charts, health data interactive, behavioral risk factor surveillance system, and births, mortality, etc. And the health indicator warehouse. Here, users can also search the data based upon the topics like whether a chronic disease and the conditions, demographics, disabilities, geography, health behaviors, healthcare resources, health outcomes, health risk factors. The hospital referral region also can also be used as a search term, or infectious disease initiative, injury or violence, or maternal or infant. Means all these terms, this which can be giving, if we are having a pictorial data, they can be used as health indicators. We can identify the risk factors like whether it is a severe chronic disease or any disability or any maternal or infant death or any referral region or infectious disease or sometime any violence. So these we can identify. And also sometimes the geographic by we also search the data by use based upon the geography. Some diseases are geographic related, so we can use either the state or the country code or initiative like country health rankings. Example like South Africa and West, they are very prone for malaria and all. So we can even get the country health rankings, and we can use these as indicators. And data is available to developers via an open application programming interface. Even we can also search by using the filters like subject, agency, sub-agency, date, coverage period start, collection frequency, geography, media format. This is mostly used in the case of health data, either government sectors or in case of insurance. So whether they have been again getting through any insurance agencies or any other sub agencies which they have been claimed by the some companies, tied up companies, or the coverage period means they have to for till which year the insurance is covered, and how many times they have covered, either the collections frequency, and geography again same, the area, country, state, city, etc., and media formats. And the enterprise data warehouse and data mining house. So how we can get the data, means how we can use this data is like based upon the clinical data, financial data, and administrative data. The enterprise data warehouse will be holding all these three data, then which can be processed by data mart, which can be again will be giving the analytics, nothing but the business analytics, which is nothing but the intelligence. So these are the steps, or this is the pathway of um, the data warehouse and then mining of the data. And the key players in health information technology are: first one, patients. The online searches for health information and research choice of physician, hospital, or insurance plan. Nowadays, even to start a small or to do if go for a small shopping, or even we will be taking the reviews. So similarly, the patient can even online search. He can search online having for the health information, and then research choice of physician. He can go based upon the ratings of the physician, and also based upon the ratings of the hospital, or else he can take an insurance plan based upon the search or the information provided. And smartphone technology for text message reminders, health and fitness apps, internet access. Nowadays everyone has, even in the mobile wristwatch, we have some apps which will be monitoring continuously our health conditions. So this is the major development we can take, we can say, which can help the persons to maintain whether they have walked this much distance per the day, or the scheduled distance per the day, like that. So this technology is more useful in monitoring the daily based activities. Even web portals for storing personal medical information, making appointments, checking lab results, e-visits, drug refills, etc. Even sometime online patient surveys. We can use this healthcare information, health information technology in online patient surveys. Online chat, blogs, podcasts, and vodcasts, support groups, and web.2 social networking. Personal health records, PHRs, limited access to the electronic health records and health information exchanges. Even sometimes telemedicine and home telemonitoring. In all these things, um, we can see the health information technology as a application. And sometimes even in case of physicians and nurses, they they can search based upon, in case of like pandemic times, they can do the online searches with PubMed, Google, other search engines, online resources, and digital libraries, or even through the WHO portal, where they can get the guidelines, WHO guidelines, so that to follow the treatment guidelines. Even patient web portals, secure email and e-visits, telehome care, and physician web portals, clinical decision support, reminders, and alerts. Even sometimes electronic medication administration record, EMAR, and barcoding medications, electronic health records, smartphones loaded with medical softwares, and remote access to EHRs. Telemedicine and telehome care, voice recognition software, online continuing medical education, and electronic prescribing, disease registries, picture archiving communication systems, pay for performance, health information organizations, e-research, electronic bill and coding for the, in case of these are the applications for physicians and nurses, and supporting staff like patient enrollment or OPD department, and electronic appointments, co- electronic coding and billing, EHRs, web-based credentialing, web-based climbings, clearing houses, telehome care monitoring, practice management software, secure patient office, email communications, online education, resources, and CME, continuous medical education, disease registries. And in case of public health, even this HIT can also be a useful app in the case of public health, like incident reports. If any reports in any incidents were reported, they can take or they can take as a cautious. And then syndromic surveillances as part of bioterrorism, and program and meaningful use program criteria, establish link to all public health departments, geographic information system to link disease outbreaks with geography, telemedicine again here, and disease registries as part of EHRs or health information in HIEs, remote reporting use of mobile technologies. And in case of federal and state governments, nationwide health information networks, financial support for EHR adoption, and HIE, development of standards, services, policies for HIT, and information technology pilot projects and grants, disease management, pay for performance again here, and electronic health records and personal health records, electronic prescribing, telemedicine, broadband adoption, HIOs, health information organizations, region extension centers, health IT workforce development, and in case of medical educators, they can get online medical resources for clinicians, patients, and staff. Means nothing but the online continuous medical in that they can update their knowledge by attending continuous medical educations, PubMed searches, and telehealth via video call, teleconferencing, podcasts, etc. And in case of insurance companies, which are the fee payers or the hospital fee payers to the patients by through any agency. They can be the agency, a third party, or second party. Electronic claims transmission. They can be using the electronic claim transmissions and trend analysis through data analytics, physician profiling, and information systems for quality improvement initiatives, monitor adherence to clinical guidelines, and monitor adherence to preferred formularies, promote claims based personal health records and information exchanges. And this reduce these are the applications. They also gives alerts to reduce the test duplication. Sometimes the patients, the hospital may claim the same report for the twice. So by using this HIT information technology, they can reduce the duplication test, and also the member of HIOs, health information organizations. And in case of hospitals also can use this, like in case of EHR's maintenance or electronic coding and billing, information systems to monitor outcomes, length to stay, disease management, etc. And barcoding, radio frequency, wireless technology, e-intensive care, e-ICUs, nothing but ICUs attached with E. They electronically they are updating the data. E-prescribing, prescription which is electronically recorded, e-prescribing, member of health information organizations, HIOs, telemedicine, picture archiving, and communication system called as PACS. And in case of again medical researchers, here also the HIT, health information technology, can act as a database creation to study populations and genetics, disease states, online collaborative research websites, electronic case report forms, ECRFs, software for statistical analysis of data, literature searches, randomization using software programs, improved subject recruitment using EHRs and email, smartphones to monitor research, online submission of grants. And in case of technology vendors, where this applying new technology innovations in the field of medicine, hardware, software, genomics, etc. This HIT plays a major role. And also in case of data mining, now the healthcare, if every hospital is maintaining the health information technology, or these are maintaining the health information which they can cloud in, if you are they have been able to accessible by the cloud technology, then everyone, if they are using, then we, by using the artificial intelligence or by using the mining, everyone can get we can even refine the treatments, and then I diagnose is very easily. And also interoperability certification. So these are the applications of HIT. And so here I want to discuss about the various forms. Is the health information technology similar to that of the information technology, where we are using this information technology in case of either manufacturing or any others? It's not like that. Why it is not like that? Why healthcare is not like any others? Because here, if we are doing any mistake, it causes either life or death. And many varied and here the varied stakeholders, strong professionals, and then evolving standards of care, fragmented, poorly conditioned systems, large, ever growing and changing body of knowledge, high volume of resources, little time. And so that's what even the healthcare also, we can in healthcare also we can use the information technology, where similar to that of banking, manufacturing. But it is not like the in case of banking, manufacturing, and any other things, the information technology is not similar to that of healthcare, because it the main variable will be either the patient may in the case of life or vitality or mortality. And why the healthcare is not like any others? See, the large variation and contextual dependence. Here the input is not a measurement which we cannot see, or we cannot measure, or we cannot, it is which is not visible, which is only observed or felt by the patient. That will be the input. Even until and then any test or the diagnostic test report, based upon that we can use like input. But sometimes we, based upon the symptoms or the complaints given by the patient, that is called as input. And which upon process is nothing but the decision making. So if the patient is coming and reporting that I have any pain or a ankle pain which has been inflamed after a fall, so he will be seeing whether the information is little or the accumulation of any. If there is an emergency, if there is a need, by taking a decision, he can send the person to take the X-ray. And similarly, the based upon the report, nothing but the output, they will get the biological response, whether any fracture or any line fractures or any other reports are there. But in case of banking, the input is again location A, from one bank, one account to, and it is the money is in the data form, it is going to transfer into one more account. So here the process is like transfer. Value added like security, convenience, and customer service. These are the value added terms. And in case of manufacturing, the value added terms are nothing but innovation, design, and then quality control. By applying these, assembling all these value added terms, the raw materials can be processed, and be outcome will be the finely or so the neatly finished goods. And in case of healthcare, the validated terms are technology, medications, and clinical knowledge and skills, quality of care, process improvement, information. All these are the validated terms which are utilized in the patient care. And the sick patient, by considering all the validated terms, the sick patient can be given patient care, and he can be converted into well patient. So here we can see the information is everywhere. The information is everywhere, and you can see as a patient, so patient as a source, files, records, and then the reports, and then photographs, and then some of the data from PubMed and all electronic data. And here the various forms of health IT. See the hospital information system. This is the photograph here. The given this the hospital information system. Even how many wards are there, how many users, how many patients inside those. These all will come under the hospital information. The details, the complete picture based upon starting from the um, base plan, and then the employees present, or duties alternate on and off, and the beds occupied, and the fees paid, the medication given, the attending nurses, and all the information of the patient and the attender for the patient, all the details will be entered into the system. The information health maintained by the hospital is called as hospital information system. Simply it can be called as HIS. And here the computerized provider of order entry, CPOE. Mm, and here the second one, the third one, this one, the electronic health records. Electronic health records, the health records of a particular patient, which can be maintained by the hospital or the healthcare department, or health information technology. Based for a particular individual is electronic health records. And this is the fourth one, picture archiving and communication system, or PACS. This is also a method of is also a type of source. And still many other forms of health information technology, like health, mobile health, and the health information exchange. So the patient at home during the COVID, they can get the information, nothing but they can get the information from the hospital, government, and also even through the mobile app, and all the websites or WHO links within the single room. Even the patient, there is no need to get out of the room, and he can sit inside the room with a communication facility, which should have an internet. There he can get the treatment and guidelines completely. And biosurveillance and telemedicine, telehealth, similar to that of this one, health information exchange, and information retrieval, and personal health records, PHRs. So here, why adopting health information technology? Whether to go for either to make easy, or to make the paperless work, or in order to decrease the size of storage of the records, or to even to computerize, or to get a health information system, or to digitalize the hospital, or to modernize, or to share data, or to have EMS. No, it is not like that. It is used the why we have to include adopt the health information technologies, in order to um, not it is not to implement technology just for technology's sake, or it is don't make use of excellent technology, or make excellent use of technology or healthcare IT, not a panacea for all that ails medicine. But the main goal is to provide good health by using value added terms like information, by applying or utilizing the tools like technology. So the why we are using, or why we are adapting this health information technology, is in order to provide good health by using value added terms, like information and technology as a tools. And these are the dimensions of quality healthcare: safety, timeliness, effectiveness, efficiency, equity, patient centeredness. So all they have to be mainly centered or concentrated upon the patient safety, timeliness, and effectiveness of the treatment, efficiency, equity, equality to all the patients, and then it is centered, morely concentrated upon the patient. Value of health IT. Value of health information technology. Guideline adherence, if you are adherence to the guidelines, and better documentation, practitioner decision making or process of care, medication safety, and patient surveillance, monitoring, patient education, reminder, all these can be obtained by using health information technology. So when we are using this health information technology, so there will be a strict adherence to the guidelines, better documentation, practitioner decision making or process of care, and medication safety, patient surveillance, and monitoring, patient counseling. See, we can never compare a health information system with the human brain or personal surveillance of a physician. But the personal surveillance of a physician, along with the health information technology, will be more effective than the simple surveillance of a single physician. So this is the theorem of informatics, fundamental theorem of informatics. We never say that health information technology is better than, it can alone is more better than the physician or supervision of physician. We cannot tell like that, but the supervision of the physician along with the health information technology, we can give better success, or we can give better patient care than the that provider, that patient care provided by the single patient surveillance of a physician. See here, the humans are not at all. In case of landmark IOM reports, the summary can be given as humans are not perfect and are not bound to make errors, make errors, because the problems in the US healthcare system that um, systematically contributes to medical errors and poor quality. Recommends reform that would change now healthcare works and how technology innovations can help improve quality and safety. Why we need health information technology? Healthcare is a very complex and inefficient if we are not applying information technology. Healthcare is information rich, but healthcare of health quality of care depends on timely availability and quality of information. And clinical knowledge body is too large, short time during a visit, practice guidelines are put on the shelf, and the error is human. These are the perception errors provided. See here, if it is like this, a big dot, that perception may, the root cause may be a blue dot, but the human sometimes imagine the root cause as the blue dot, which has been given as a small dot in this enlarged picture, and then he may think, he may ground, or he may do the survey in other less risk factors. So these are based upon this is the error mm, error due to the human perception. This all happens due to lack of attention, because of his high duties, continuous duties, or lack of attention, or personal problems of his anything. Due to lack of attention, we can get errors of human. This can be like cognitive errors, example decoy pricing and all. And here the economic purchase options like economist subscription, print web subscription, these are also cost effective. Still we can minimize the cognitive errors, example this is not related to health, so we can even minimize the cognitive errors by using health information technology, that which is possible by a human. What if this happens in case of healthcare? If it is the human error is happening in case of healthcare, it already happens, because he is already comparing he is coming to the physician or any health organization to get benefited. Instead of getting benefited, if he gets again one more error or delay in the proper diagnosis, it will affect. But if what if health IT can help? See here, by adopting this health information technology and using the assumptions like adoption, we and using, and the outcomes is will give you the better patient care and easy diagnosis. So here we will make wider use of electronic records and other health information technology to get control costs of reduced dangerous medical errors. This was stated by President George W. Bush in the Sixth State of Union Address, January 31st in 2006. So by using or by applying this information technology, by adapting this human health information technology, we can minimize the human errors. So this is the significance. This about the significance of the health information technology, and these are the policies like IOM CPR report published, and in the case of adoption of EHRs or regional extension centers, workforce time training, we can get adoption of EHRs, electronic health reports, meaningful use of electronic health reports, and exchange of health information, HIE, and we'll get by using all these things, standards and center certification framework, and means these terms like very strictly adhering to the guidelines, and then adoption of EHRs and all these things will give improved individual and population health outcomes, increased transparency and efficiency, and improved ability to study, improve care delivery. Means the patient care will be more improved or the better. By using this healthcare information technology, we can use the meaningful use. See, this will be the pumpkin looking like the big data source. That data source, in order to define, to search all the paper records and all, will consume more time. But to consume, instead of consuming the whole pumpkin, we can extra the content which is converted into a meaningful pumpkin is nothing but the whole. This can be processed and has been converted into a very tasty some of the dish, like is nothing but meaningful use of a pumpkin. There's nothing but the data, which is a very vast, which is very having a huge size, can be further processed, and then it is converted into information. Based upon the information, one can gain knowledge, and then by utilizing or by judging the taking all these things, we can attain some wisdom, which will, by using this wisdom, once one can provide, or the better patient care can be given to the patient or healthcare system. The meaningful use of health is utilized of health IT is like stage one, electronic capture of health information, information sharing, data reporting, and in case of use of EHRs to improve processes of care. And third stage, in the stage one, all the things are capturing information, and then in case of using EHRs to improve processes of care, and the third stage, use of EHRs to improve outcomes. This will all give a better health. And health IT applications, these are enterprise wide hospital IT, like the master patient index, MBI, all these things, picture archiving, all we have discussed already. But nursing applications, sometimes this HIT is also used in nursing applications, enterprising resource planning, ERP, and departmentals, like in case of pharmacy applications, laboratory information systems, specialized applications, and incident management. In case of now, previously the one person has to go to the pharmacy, and then he has to take the prescription, and he has to get the medication to the ward. Now nowadays, by applying, by adapting this departmental information technology, health information technology, even the e-filling can be done for the prescription, thereby automatically dispenses to the dispensary. There is no, we can minimize the time consumption in getting the medication, and also we can minimize or reduce the queue or waiting times, or to get the reports from the laboratory place to the ICUs, or which can say where the uh, time consumption or lapse in the time may give a very bad worse scenarios, will result in a bad worse. So the proper adoption of all these things, electronic reports generating, and then which can be accessed by the physicians in the ICUs, can minimize the consumption of time, which can save lives, so that we can give more better patient care or better patient care. EHRs and HIS. EHRs are nothing but the electronic health reports, health records, and health information system. The electronic health records are nothing but the electronic medical record. These are all like seen previously. We when we go to the hospital, we are taking the OP card. They will ask us today stay out there for some time, and then they will be bringing our whole history, our file for after some time. But now there is no need. If you are having an ID, electronic health records, or by having the electronic medical records, just by clicking the ID or the user ID or the ID given for you, the number, if they can access the all the records, those the size. Here by applying this health information system, we can reduce the size occupying of files and the time in searching and searching and taking out the single patient's medical file or his health record, and also it can be accessed from anywhere if it is available, or it can be transferred from one hospital organization to another hospital organization also. And the computer based patient records, which again the personal health records, if they are all maintaining, this will be enhancing, or it will be giving to provide better patient care. EHR system. These are nothing but just electronic documentation. No, not like that. This contains history of the patient, past and diagnosis, and then treatments. And again, if any needed, this information is again also used to know the cause, more likely interactions or possible any other things like drug interactions or any other and he's going, if he's not maintaining all the past history of medication, the patient may not that much educated, or he is not that much able to remember all the medications what he is undergoing, and he has gone to the physician and he forgot to tell about a proper medication which has a significant interaction to the drug, to the disease, current disease which he has been prescribed. So in order to divide of all these unwanted interactions. So if we are maintaining electronic health record system, it will be saving life, or we can give some more better patient care. And these are the functions that should be part of EHR system. Computerized medication order entry. We have to use computerized medication order entry, computerized laboratory order entry, computerized laboratory results, physician notes, patient demographics, problem list, medication list, discharge summaries, diagnostic test results, radiologic reports. And these are the computerized pharmacy physician order entry, CPOE. And in case of CPOE values, there should not be any handwriting. The structured data entry, automatic generated format on that system, they have to enter the data completely in a complete manner with a clear and then fewer mistakes. And no transcription errors will be there. Entry point for the CDSS, and then streamlines workflow, increases the efficiency. Because of maintaining this CPOE, we can get efficiency increased. And in case of clinical decision support systems, the real place where most of the value of health IT can be achieved, like expert systems and examples, differential diagnosis, treatment options. And again, they can also this alerts and reminds based upon the alerts and reminders based upon specific logical conditions. Examples: drug allergy checks, as we discussed, drug interaction checks, drug disease checks, drug lab checks. Sometimes if he is having a tablet and then he's going for a check, then he may get the laboratory reports wrong laboratory reports, or which will hide some of the important thing. And then drug formulary checks, reminders for preventive service or certain actions, clinical practice guideline integration. Clinical decision support. This again, the CDSSs will again give also the evidence-based knowledge sources. Example: drug database, and then literature. We can have a evidence-based knowledge. It means simply the physician cannot say that as he has seen or somewhere he has seen, or in that case, but he has an evidence-based knowledge. We should not take the test by consuming or consuming the particular drug, or he cannot. So he can have any evidence based knowledge. This will be more useful, and which can give a better health care to our patient. And a basic this architecture of CDSS is like user interface, interference engine, other data. This knowledge-based patient data is nothing but the given info data, raw data given by the patient, and the knowledge base which can be given by the by accessing adapting the HIT, and other data like system states, epidemiological surveillance data, geographical data, and all those things. All by considering all these data and knowledge base like rules, statistical data, literature, etc. By applying this HIT, adapting, we can get interference engine, user interference, and then the user can be benefited, or we can use this in as a CDSS. Here, in case patient given he have some perception and he has paid some attention, whether he may think that he has having some pain over there, and then it was his perception and his attention. After paying some attention, he can more memorize, or he can more remember, whether it is a memory, and then he can it can become a long-term memory based upon the knowledge and data, based upon his attention, and then notifications, all the observations. And then this sometimes this attention may give external memory, knowledge and data, and this working memory is nothing but after paying his attention, sometimes after his inference he can go and then to a patient, physician, and complain about all these things. Then the clinician can take a decision, required decision. Sometimes if the abnormal abnormal lab highlights are given, then drug allergy checks we have to check. Means either this if he pays some attention, he can identify or diagnose after taking some drug. He can tell that as a drug interaction or a drug allergy. Simply one drug means he can may have drug allergy, or if he is obtaining such type of pain or allergy after having a drug priorly continuously, and then now he has taken a new drug, then it can be identified as drug interaction, and then clinical practice guidelines in reminders, and the inference like based upon all his attention and all those things, he can based upon all the inference of the clinician, he can be sent for a diagnostic or treatment expert systems. So as I discussed previously, here, then never the computer, the HIT is not more effective than the human brain, but here the Greek oracle model, in case of by adapting this technology, CDSS as a replacement of supplement of clinicians. And they have told that the Greek they have a model. They have told that this is like HIT is more better than the physician surveillance or his personal thing. But this fundamental theorem tells both the physician surveillance and the HIT in combination will give more better patient care than the simple physician attention. So this is about the healthcare information technology and the uh, uh, scope of healthcare information technology, and the web of the world, utilizing the web, the last topic of the first unit. And tomorrow I'll be continuing with the impact of HIT on healthcare. Already we have covered most of the part, and then impact of the HIT on government, impact on government, and last mode that if we are covering that, unit 1 will be finished now. Thank you. Is there any doubt? Any doubt? Any doubts? Am I audible? Is there any doubt? If any doubts, please raise.
No,
You
ma'am.
can raise your hand. Thank you. is a dry subject only, but if you are remembering and if you are applying with your some of the observed scenarios of the hospitals, you can easily remember the subject and you can reproduce well in your exams. Thank you.
Good afternoon, everyone. Am I audible? Good afternoon, everyone. Am I audible? Okay. Uh, so today we are going to see a bit boring topic, national health programs, and these are actually dynamic topics because the things which we tell today might not be the same today, tomorrow, and a new program might be or a modified program might be launched, and the activities in the program will keep changing day by day. Okay. So one of, we will see today few programs among national health programs. Okay. So first we will see National Leprosy Eradication Program. The components of the program are as follows: decentralized integrated leprosy services through general healthcare system. So what is the meaning of decentralized integrated leprosy services? So previously there was leprosy special hospitals. Now the main idea through this program is to decentralize, means make available of leprosy treatment everywhere through general healthcare system. Capacity building of all general health services functionaries, intensified information, education and communication among people, doctors and patients, prevention of disability and medical rehabilitation, intensified monitoring and supervision. Major initiatives in this program include: more focus has now been given to new case detection than prevalence. So new case detection means incidence. Prevalence means previously existing cases along with new case detection. So more focus has now been given to new case detection than prevalence, which only gives the number of cases on record at a point of time. The new case detection rate is the main indicator for program monitoring. Treatment completion rate has been taken as an important indicator to be calculated by states at yearly basis. More emphasis is being given on providing disability prevention and medical rehabilitation services to leprosy affected persons. The aid provided is as follows: dressing materials, supportive medicines, and ulcer kits are provided to patients. Microcellular rubber footwear, which we call as MCR footwear, is provided for protection of insensitive feet. What is insensitive feet? Okay. There are certain methods like pin pricking methods over the sole. They will give sufficient pressure with that pin, if and they will measure on a pain scale method. If there is no measurement, no sensitivity to pain, the foot is called as insensitive foot. For those patients with insensitive foot, MCR chappals are provided. 41 NGOs in the country and 42 government medical colleges have been strengthened for providing reconstructive surgery services to leprosy affected persons for correction of their disability, thus totaling to 83 centers for conducting reconstructive surgeries in the country. An amount of rupees 5,000 is provided as incentive to each leprosy affected person from BPL family, which means below poverty line family, undergoing reconstructive surgery in these identified institutions to compensate for loss of wages. Support is also provided to government institutions, PMR centers in the form of rupees 5,000 per reconstructive surgery conducted. Ashas have been involved in bringing out suspected leprosy cases from their villages for diagnosis and treatment at primary health center and follow-up of confirmed cases for their treatment completion. To facilitate the involvement of ASHA in the program, they are being paid incentive money. On confirmed diagnosis of case brought by them, rupees 250 is provided. On completion of full course treatment of the case within specified time, for a paucibacillary leprosy case, which means 6 months of treatment, and a multibacillary leprosy case, which means 1 year of treatment, 400 and 600 is provided respectively. An early case before onset of any visible deformity, rupees 250 is provided. A new case with visible deformity in hands, feet, or eye, rupees 200 is provided. Activities to be performed by ASHA are as follows. Search for suspected cases of leprosy, that is before any sign of disability appears. Such early detection will help in prevention of disability and also cut down transmission potential. Follow all cases for completion of treatment in scheduled time. During follow-up visit, also look for symptoms of any reaction due to leprosy and refer them to the health workers PHC for treatment. This will again reduce chances of disability occurring in cases under the treatment. Advise and motivate self-care practices by disabled cases for proper care of their hands and feet during the follow-up period. This will improve quality of life of the affected persons and prevent deterioration of disabilities and spreading awareness. Guys, how is leprosy spread in community? Will I get leprosy if I touch a leprosy patient? The answers are great no. Okay. If leprosy is an airborne disease, if you touch a leprosy patient, you are not going to get leprosy. So there is no harm in touching a leprosy patient. Okay. But masks are mandatory while handling leprosy patient. Okay. There are 612 self-settled colonies in the country where more than 50,000 leprosy affected persons reside. Free medical facilities like care of ulcers, self-national leprosy eradication program, 455 care training, counseling and MCR footwear are provided to leprosy affected persons residing in these colonies through paramedical workers, NGOs on weekly or fortnightly basis. Intensive campaign with a theme towards leprosy-free India has been carried out towards further reduction of leprosy burden in the community, early reporting of cases and their treatment completion, provision of quality leprosy services, and reduction of stigma and discrimination against leprosy affected persons. Awareness generation activities are carried out through mass media and local media. Disability prevention and medical rehabilitation. The main activities carried out under disability prevention and medical rehabilitation are as follows. Implementation of DPMR activities as per guidelines and reporting its outcome. Example, treatment of leprosy reaction, ulcers, physiotherapy, reconstructive surgery, and providing MCR footwear. Integrating DPMR services. These are provision of services to persons with disability by various departments under different ministries. Convergence of MLEP services into NRHM facilities in this integration. To develop a referral system to provide prevention of disability services to all leprosy disabled persons in an integrated setup. To achieve the objectives of the plan, the main strategies to be followed are integrated leprosy services through general healthcare system, early detection and complete treatment of new leprosy cases, carrying out household contact survey for early detection of cases, involvement of ASHA in the detection and completion of treatment of leprosy case on time, strengthening of DPMR services. Okay, this one slide is a concise of all those slides spoken prior. Okay, Sparsh Leprosy Awareness Campaign was launched in the year 2017 through Gram Sabhas and carried out with the help of Panchayat and village health and sanitation community. The aim of this campaign was to generate awareness, reduce stigma, and improve self-reporting of these cases. The campaign activity was carried out in 60% of total village across India. The campaign was to continue during the year 2018. Incentive to patient. An incentive of rupees 8,000 will be paid to all affected by leprosy undergoing major reconstructive surgery irrespective of their financial status. Previous incentive was based on BPL, below poverty line status. Now the incentive is given irrespective of their financial status. The payment will be made by the district leprosy officer. As on January 2017, there were 115 recognized RCS centers, out of which 61 government and 54 NGO in the country. Next, we move on to revised National Tuberculosis Control Program. It is still further revised to National Tuberculosis Elimination Program, but today we will see the main features of revised National Tuberculosis Program. The objectives of the RNTCP are achievement of at least 85% cure rate of infectious causes of tuberculosis through DOTS, which means directly observed treatment strategy involving peripheral health functionaries, and augmentation of case finding activities through quality sputum microscopy to detect at least 70% of estimated cases. DOT strategy adopted by revised National TB and Control Program initially had the following 5 components: political will and administrative commitment, diagnosis by quality assured sputum sphere microscopy, adequate supply of quality assured short course chemotherapy drugs, directly observed treatment, systematic monitoring and accountability. In 2006, Stop TB strategy was announced by WHO and adopted by RNTCP. The components of this scheme are as follows: pursuing quality DOTS, expansion and enhancement, addressing TB bar HIV and MDR-TB, contributing to health system strengthening, engaging all healthcare providers, empowering patients and communities, enabling and promoting research. So RNTCP endorsed TB diagnostics. Sorry, smear microscopy for acid-fast bacilli. Sputum smear stained with Zeal-Nelson staining or fluorescent stains and examined under direct or indirect microscopy with or without LED. This is same in NTEP. Okay, not when changed. Next, culture. Solid culture, Lowenstein junction media or liquid culture middle group using manual, semi-automatic or automatic machines, example backtech, inkjet, etc. This is also remaining same in the revised guideline. Okay. Out of solid and liquid media will yield earlier growth compared to solid media. Okay. Next, rapid diagnostic molecular test. Conventional PCR based line probe assays for MTB complex. Real-time PCR based nucleic acid amplification test, which we will call shortly as NAT, for MTB complex, also called as gene expert test. This gene expert test is not available in primary health center level. It is only available at district health hospital levels, and it will yield reports within 1 day. Okay, whether the culture will yield reports in 1 to 2 weeks, even 3 to 4 weeks for solid media induced culture. Okay. The main advantage of NAT for MTB complex or gene expert, it will also detect drug resistance to tuberculosis treatment, mainly isoniazid resistance, okay, which is one of the prime drug in the treatment of tuberculosis. Radiography were available, which is chest X-ray, CT scans, tuberculin skin test, which is also called as Manto test, The reliability and sensitivity is bit less in adult population, but it has a great sensitivity in child younger population. Okay, so all these RNTCP endorsed TB diagnostics remain same in the updated National Tuberculosis Elimination Program also. Okay. Next, new initiatives, NICSHI, TB surveillance using case-based, web-based ET system. It is actually a computer-based system. NICSHI is nothing but computer-based system. Central TB Division, in collaboration with National Informatics Center, has undertaken the initiative to develop a case-based, web-based application named NICSHI, which means simple. If you detect a tuberculosis case, the data of the patient should be entered in a system which can be accessed anywhere across the country. Okay. The word is combination of two Hindi words, "ni" and "kshay", meaning eradication of TB. This software was launched in May 2012 itself and has following functional components: master management, user details, where you are going to give TB patient registration and details of diagnosis, who is providing the daily observed treatment, HIV status of the patient, follow up, contact tracing, and outcomes of the patient. This is the main highlight of this NICSHI program. Details of solid and liquid culture and DST, LPA, CVNA details if done. Drug resistant TB patient registration with details. Referral and transfer of patients. Private health facility registration and TB notification. Mobile application for TB notification. SMS alerts to patients on registration. So all these documents will be enrolled in the information bulletin. Okay. SMS alerts to program offices, automated periodic reports, case finding, sputum conversion, treatment outcome. The program has started using IT-enabled adherence tools like 99 dots for HIV-TB patients. This will be expanded to all TB patients with implementation of daily regimen. Next, TB notification. In order to ensure proper diagnostics and management of TB cases and to reduce TB transmission, and the emergence and spread of MDR-TB, it is essential to have complete information of all TB cases. According to Government of India notification dated 7th May 2012, it is now mandatory for all healthcare providers to notify every TB case to local authorities. So even if you are a private practitioner, in your private practice, if you are diagnosing tuberculosis, you have to report it. Okay. Ban on TB serology. The serological tests are based on antibody response, which is highly variable in TB and may reflect remote infection rather than active disease. Currently available serological tests are having poor specificity and should not be used for diagnosis of pulmonary or extrapulmonary TB. Their import, manufacturing, sale, distribution, and use is banned by the Government of India. Direct benefit transfer schemes. Direct beneficiary transfer system are being established by linking TB patients reported in NICSHI with Aadhaar and PEMS to effectively deliver benefits to TB patients and their providers. National Strategic Plan 2017 to 2025 for TB elimination. The main objectives are: find all drug-sensitive TB and drug-resistant TB cases, with an emphasis on reaching TB patients seeking care from private providers and undiagnosed TB in high-risk population. Initiate and sustain all patients on appropriate anti-TB treatment wherever they seek care, with patient-friendly systems and social support. Prevent the emergence of TB in susceptible population. Build and strengthen enabling policies, empowered institutions, additional human resources with enhanced capacities, and provide adequate financial resources. The key strategies are as follows: private sector engagement, active case finding, drug-resistant TB case management, addressing social determinants including nutrition, robust surveillance system, community engagement, and multi-sectoral approach. The aim of National Strategic Plan is to achieve elimination of TB by 2025. During plan period, the targets include 80% reduction in TB incidence, That is reduction from 211 per lakh to 43 per lakh. 90% reduction in TB mortality. That is reduction from 32 per lakh to 3 per lakh. 0% patient having catastrophic expenditure due to TB. Actually, this is in routine. If we see, there is a drastic reduction, which is indicating the success of the program. Okay. Next, we'll see National AIDS Control Program. So before going to that, we have MTEP, the current modified tuberculosis national program, which was previously named as RNTCP. Now it has been renamed as NTEP, National Tuberculosis Elimination Program, because we have achieved this 80% reduction in TB incidence. So now it is not a control program anymore. It is an elimination program. Okay. So major changes in this elimination program are actually in the treatment perspective, which is not much required for you people and which is more required for physicians. Okay. And the strategies in diagnosing, identifying, implementing all almost remain same as compared to the previous system. The main change is in treatment. The two treatment of multi-drug resistant and extremely drug resistant treatment cases. Okay. And in only one thing on diagnostics, there's a change. Newly, they have launched IGRA in screening patients with high risk. Okay. Then, yes, these are the few changes in NTEP program. Okay. Next, we move on to National AIDS Control Program. The milestones of the program are summarized. In 1986, first case of HIV was detected. AIDS Task Force set up by the ICMR, National AIDS Committee established under the Ministry of Health. People, do you know where the first case of HIV was detected? It is in United States. People, do you know where the first case of HIV was detected in India? It is in Chennai. Okay. So after 1986, when they detected the first case of HIV, they did AIDS, they did not know the positive organism was HIV. 1 year later, only they found the organism to be HIV, human immunodeficiency virus. Later, HIV detection kits were I discovered. After the discovery of HIV detection kits, there was a drastic increase in number of HIV cases. Okay. So in 1990, medium term plan launched for 4 states and the 4 metros. NACP1 launched to slow down the spread of HIV infection. National AIDS Control Board constituted. NACO was set up. In 1999, NACP2 begins focusing on behavior change, increased decentralization, and NGO involvement, and state AIDS control societies were established. In 2002, National AIDS Control Policy was adopted. National Blood Policy was adopted. In 2004, antiretroviral treatment initiation. In 2006, National Council on AIDS constituted under chairmanship of the Prime Minister. National Policy on Pediatric ART was formulated. In 2007, NACP 3 launched for 5 years. In 2014, NACP 4 was launched for again 5 years, from 2012 to 2017. In 2017, National Strategic Plan for HIV, AIDS, and STDs for launch, which was for a cumulative period of 2017 to 2024. Prevention services. Targeted interventions for high-risk groups, female sex workers, men who have sex with men, transgenders, hijras, injecting drug users, and bridge population, truckers and migrants. needle syringe exchange program, and opioid substitution therapy for intravenous drug users. Prevention interventions for migrant populations at source, transit, and destination. Link worker scheme for HRGs, high risk groups, and vulnerable population in rural areas. Prevention and control of sexually transmitted infection, reproductive tract infections. Blood safety, HIV counseling and testing services. If you notice, in every GH, government hospital district headquarters, there is an HIV counseling room and there will be a HIV counselor. As soon as you detect HIV positivity in a patient, it is not directly conveyed to the patient as such. It is the role of HIV counselor to convey the positivity in the patient, and the counselor also informs do's and don'ts further. And regarding the availability of treatment and the free treatment availability and risk side effects, everything will be counseled by the HIV counselor. Okay. Prevention of parent to child transmissions, which is actually called vertical transmission. Okay. Condom promotion to reduce the number of cases in sexually active individuals. Information, education, and communication and behavior change communication, social mobilization, youth interventions, and adolescence education program. Mainstreaming HIV or AIDS response, workplace interventions, care, support, and treatment services, laboratory services for CD4 testing and other investigations. So, what is CD4 testing? CD4 is a type of lymphocyte which is a T lymphocyte which will be drastically reduced in patients with HIV. And there will also be CD4 CD8 reversal ratios in patients with HIV. This CD4 level are important in identifying the immune status of the individual. Lower the CD4 levels, lower the immune status of the patient. So our target is to improve the CD4 levels by providing treatment, by providing early diagnosis. An AIDS patient will not die per se because of AIDS. An AIDS patient will die mainly due to secondary infection, which can be tuberculosis, which can be cryptococcus, which can be cancers, which can be Kaposi sarcoma, which can be lymphomas, etc., etc., etc. Secondary opportunistic infections are there in HIV patients. So when this secondary acquired opportunistic infection will happen in an AIDS patient, when their CD4 count drops less than 400. So our aim is to maintain CD4 count more than 400. Okay. Free first line and second line antiretroviral therapy through ART centers and link ART centers, Center of Excellence, and ART Plus centers. So, what is first line and second line antiretroviral therapy? It is not much different. A first line therapy, when has a resistance, you are going to move for a second line therapy where you will introduce a different class of drug. Okay. Next, pediatric ART for children who has acquired AIDS through vertical transmission from mother to child. Early infant diagnosis for HIV exposed infants and children below 18 months. Nutritional and psychosocial support through care and support centers. HIV TB coordination. Treatment of opportunistic infections. Drop-in centers for PL HIV networks. And also importantly, never ever write HIV positive or AIDS in your discharge summaries. Always you have to mention as PL-HIV, which means people living with HIV. Okay. Never ever mention as AIDS or HIV state, HIV positive. You have to mention as PLWH. Even PLHIV is not used. PLWH, people living with HIV. Okay. That has to be the term mentioned in discharge certificates. Group 1, high prevalence states including Maharashtra, Tamil Nadu, Karnataka, Andhra Pradesh, Manipur, Nagaland, where HIV infection has crossed 5% mark in high risk group and 1% or more in antenatal women. Guys, do you know which is the leading district in Tamil Nadu with high number of cases? Anyone? Okay. Previously it was Namakkal, now it is Krishnagiri. Okay. Group 2, moderate prevalence states. This includes states of Gujarat, Goa, and Puducherry, where HIV infection has crossed 5% or more among high risk groups, but the infection is below 1% in antenatal women. Group 3 low prevalence states includes remaining states where the HIV prevalence in any of the high risk group is still less than 5% and is less than 1% among antenatal women. The type of surveillance are HIV sentinel surveillance, HIV sero surveillance, AIDS case surveillance, STD surveillance, behavioral surveillance, integration with surveillance of other diseases like tuberculosis, etc. The objectives of the surveillance are as follows: to determine the level of HIV infection among general population as well as high risk groups in different states. To understand the trend of HIV epidemic among general population as well as high risk group in different states. To understand the geographical spread of HIV infection and to identify emerging pockets. To provide information for prioritization of program, resources, and evaluation of program impact. To estimate HIV prevalence and HIV burden in the country. So, prevention. TB HIV coordination is to reduce mortality, which will include isoniazid preventive treatment. So, any patient with tuberculosis with HIV, you have to provide isoniazid prophylaxis treatment for a period of 6 months, which they are telling us isoniazid preventive treatment. Next, airborne infection control. How can we do it? By providing mask. Awareness generation. By providing counseling and awareness via posters, WhatsApp messages, newspapers, news channels, etc. Next, early detection of TB HIV association. 100% coverage of PITC in TB patients. PITC in presumptive TB cases. Rapid diagnostics for TB detection and drug resistant TB in people living with HIV. ICF activities at all HIV settings like ICTC centers, ART centers, LAC centers, and TI settings. So there is some special things in here. Any patient, if you detect tuberculosis, mandatorily has to undergo HIV testing. Any patient, if you diagnose HIV, mandatorily they have to go for screening of tuberculosis via sputum and chest x-rays. This is one point to be noted here. Then, suppose in tuberculosis, we discussed CBNAT or gene expert award. In a HIV negative patient, you cannot ask for CBNAT testing of sputum directly unless you have sputum smear positive or negative reports, which means HIV negative patient, step 1, sputum smear for AFB, whether report is positive or not. Second step is only CBNAT. Now you may ask a question, already it is positive, why I have to do CBNAT in such individuals? Because CBNAT will also give isoniazid resistant status in individuals with tuberculosis. So CBNAT testing is mandatory for all individuals, even though if they are TB positive in sputum AFB itself. Okay. Now sputum is negative. Still clinically you are suspecting tuberculosis, you are going for sputum CBNAT. But this is not the case with HIV positive individuals. Sputum smear is not required. Directly you can order for sputum CBNAT. The sensitivity and specificity is very high. Okay. Next, prompt treatment of TB HIV combination. Early initiation of ART. Prompt initiation of TB treatment. Okay. Now, there is a question. My patient is having both tuberculosis and HIV, for which I will start treatment first, whether TB or HIV. So here comes the role for CD4 counting. If CD4 count is less than 200, which means patient's immunity status is very much low, in such cases, you start treatment of HIV first. After 2 weeks, start tuberculosis treatment. In count more than 200, postpone the treatment for 2 months. Start HIV treatment, start treatment of tuberculosis after 2 months. Okay. Next, management of special TB by HIV cases. TB HIV patients on PI based ARV. PI means protease inhibitor based ARV. Okay. Actually, there is a recommendation in PI based ARV because of cross reactivity with rifampicin, one of a tuberculosis drug. Okay. These things no need to be dealt in detail to you people. Okay. Next, TB HIV program in children, TB HIV in pregnant women, drug resistant tuberculosis, and HIV also. Previously, CD4 count were deciding the treatment of HIV itself. Nowadays, the newer health program suggests, irrespective of CD4 count, if HIV is positive, instantly and immediately you have to start HIV treatment. There is no role of CD4 count for starting treatment in HIV positive patients. But whenever there is HIV TB co-infection, there also you are going to treat both, but time gap of 2 weeks to 2 months will be decided by CD4 count. That's all. Okay. First line ART is provided free of cost to eligible people living with HIV through ART centers. Positive cases referred by ICTCs or registered in ART centers for ART and services. The assessment for eligibility for ART is done through clinical examination and CD4 count. This third point is changed now. There is no CD4 count based eligibility for starting ART. Okay. Patients are also provided counseling on treatment adherence, nutrition, positive prevention, and positive living. Follow-up of patients on ART is done by assessing drug adherence, regularity of visits, periodic examination, and CD4 counts every 6 months. Treatment for opportunistic infection is also provided through ART centers. Till August 2017, 11.33 lakh people living with HIV were on first-line ART. Alternative first-line ART, it has been observed that a small number of patients initiated on first-line ART experience acute or chronic toxicity or intolerance to first-line ARV drugs, thus necessitating change of ART drugs to alternative first-line drugs. Presently, the provision of alternative first-line ART is done through Center of Excellence and ART Plus centers across the country. Not everywhere it is available. The second-line ART began in Jan 2008 at two sites, GHTM Tambaram, Chennai and JJ Hospital Mumbai on a pilot basis, which means first time, and was then further expanded to other Center of Excellences in January 2009. Further decentralization of second-line ART was done through capacitating and upgrading some well-functioning ART centers as ART Plus centers. Till March 2014, 8,897 patients were receiving second-line drugs at Center of Excellence and ART Plus centers. All people with centers are linked to COE or ART Plus centers. For the evaluation of patients for initiation on second line and alternate first line ART, a state AIDS clinical expert panel has been constituted by DAC at all COEs and ART Plus centers. This panel meets once in a week for taking decisions on patients referred to them with treatment failure, major side effects. Third line ARTs, some patients on second line ART also experience treatment failure. For those people, you have to go for third line ARTs. National program rolled out third line regimen for them in 2015. Currently, Raltegravir and Darunavir are used for third line regimen. HIV TB co-infection. TB is the most common opportunistic infection among people living with HIV. All patients attending ART centers, including new registrations, pre-ART and on ART patients, are screened verbally for 4 symptom complex: cough, fever, weight loss, and sputum production. Okay. In case any one of the symptoms present, patient are referred for TB testing. So as I mentioned, all patients with HIV to be screened for tuberculosis. Okay. Those diagnosed with co-infection or initiated on anti-TB treatment from ART center followed by ART center. Okay. Followed by ART. Okay. When TB is ruled out, isoniazid prophylaxis is offered. This also I have mentioned previously. Isoniazid prophylaxis will be ordered for 6 months. NACP works in close coordination with RNTCP for managing co-infections. The PL-HIV are at high risk for comorbidity with hepatitis B and C also. It is important to ensure timely detection and initiation of hepatitis B or hepatitis C treatment for HIV viral hepatitis co-infected patients to minimize hepatitis-related liver disease and its long-term negative impact on HIV outcomes. Hepatitis B and C detection and treatment for PL-HIV will be provided at ART centers itself. Hepatitis B treatment is available as a part of ART program since ART regimens containing TDF, tenofovir, dolutegravir, and tenofovir, lamivudine, and dolutegravir. Okay, plus a second line NRTI active. Sorry, TDF means it is tenofovir only. Plus a second NRTI active against HBV have been shown to suppress both HIV and HBV viral replication. Treatment for hepatitis C needs direct acting antiviral such as sofosbuvir, grazoprevir, glicapavir, etc. I will tell shortly. For hepatitis B and HIV treatment, no added drug. The HIV treatment itself is sufficient for hepatitis B also because the regimen is tenofovir, lamivudine, and dolutegravir. These three are the current first-line treatment for HIV. Out of these three, lamivudine and tenofovir will also act against hepatitis B. So keep it simple. Hepatitis B, HIV, no extra treatment. HIV treatment itself will be the treatment for hepatitis B. That's all. Okay. Next, for hepatitis C and HIV co-infection, you have to separately treat the hepatitis C, because the HIV drugs will not act for hepatitis C. And also you have to notice HIV and hepatitis B treatment are lifelong. Hepatitis C is only for 3 months, which is 12 weeks duration. And sofosbuvir plus daclofosfir combination or sofosbuvir plus velpatasvir combination is prevalently used, because in hepatitis C, again, there are genotype specific drugs. Among hepatitis C, type C genotype is more common, and sofosbuvir plus velpatasvir combination will act for all genotypes. So that is the preferred regimen. Okay, with HIV or without HIV. Hepatitis C means prefer sofosbuvir plus velpatasvir or sofosbuvir plus daclofosfir. Even in HIV positive individuals, the treatment remains again same. Sofosbuvir plus velpatasvir or sofosbuvir plus daclofosfir. Okay. Next, HIV Kala-Azar co-infection or visceral leishmaniasis is endemic in some districts of states like UP, Bihar, and Jharkhand. I have never seen a case of Kala-Azar with or without HIV in my practice so far. It is almost eradicated, okay? But still, control programs has to mention these co-infections for awareness among physicians also. All people with HIV with symptoms suggestive of Kala-Azar are screened for Kala-Azar, and those found infected are referred for appropriate treatment centers. Other opportunistic infections. People living with HIV are regularly screened for co-infection and comorbidities. Those diagnosed having these are treated appropriately at ART center or referred to concerned facility. Those who are vulnerable to opportunistic infection or due to low CD4 count or any other reasons are provided with prophylaxis, for example, cotrimoxazole. Cotrimoxazole is a drug which is provided for pneumocystis jirovecii co-infection in HIV. Okay. The services offered through targeted interventions, detection and treatment for sexually transmitted infection, condom distributions, condom promotion through social marketing, behavior change communication, creating an enabling environment with community involvement and participation. Linkages to integrated counseling and testing centers. Linkages with care and support services for HIV positive in high risk groups. Community organization and ownership building. Specific interventions for intravenous drug users. Distribution of clean needles and syringes. Abscess prevention and management. Opioid substitution therapy. Linkage with detoxification and rehabilitation services. Specific intervention for MSM bar TGs. Provision of lubricants. MSM means male to male sex workers. Okay. TGs means transgenders. So provision of lubricants, specific intervention for transgenders or Hijra population, provision of project-based sexually transmitted infection clinics. So you will be hearing at your childhood or some 10 years before a famous advertisement, Pulli Rajaku AIDS Verma. So what does that mean? Pulli Raja. Pulli Raja, do you think that people with HIV are going to have some pulli like rashes? It is no. Okay. So it is simply to develop curiosity. So Pulli Raja to AIDS Verma. Okay. Pulli Raja, who is that Pulli Raja? AIDS na? What is AIDS? So people will start asking questions. So it is a term introduced only to develop curiosity. There is no direct meaning for that Pulli Raja. It means not a person with rush. It is only a word to develop curiosity among population. Okay, people will start questioning. Pulli Raja na enna? AIDS na enna? AIDS na enna, HIV na enna. So by questioning, they will be becoming aware. By becoming aware, you can reduce number of cases or early case detection, treatment, successful treatment, and lifetime of the people with HIV is going to increase. Nowadays, people living with HIV are having a near normal life expectancy like us, because the treatment is very nicely effective against HIV. Okay. Next, STD control program. NACO has branded the sexually transmitted infections or reproductive tract infections services as Suraksha Clinic. The color code is as follows. Kit 1, gray color for urethral discharge, anorectal discharge, and cervicitis. Kit 2 means green for vaginitis. Kit 3 means white for genital ulcers. Kit 4 means blue for genital ulcers. Kit 5 means red for genital ulcers again. Kit 6 means yellow for lower abdominal pain. Kit 7 means black for inguinal bubo. What is this color code? What difference this color code is having? It is simply each color code will have different drug regimen. That's all. Since it is based on drugs, I have not mentioned in detail. Okay. But you have to just remember that for different sexual symptoms, different treatment is available, and that treatment is made easily with a color coded kit. That's all. Okay. Next, National Program for Control of Blindness. Main objective of the program in the 12th 5-year plan period are to continue 3 ongoing signature activities, that is performance of 66 lakhs cataract operations per year, school eye screening, and distribution of 9 lakhs free spectacles per year to school children suffering from refractive errors, and collection of 50,000 donated eyes per year for keratoplasty. To reduce the backlog of avoidable blindness through identification and treatment of curable blind at primary, secondary, and tertiary levels based on assessment of the overall burden of visual impairment in the country. Develop and strengthen the strategy of National Prevention Program for Control of Blindness for e-health for all and prevention of visual impairment through provision of comprehensive universal eye care services and quality service delivery. Strengthening and upgradation of Regional Institute of Ophthalmology to become Center of Excellence in various subspecialties of ophthalmology, and also other partners like medical colleges, district hospitals, sub-district hospitals, vision centers, NGO eye hospitals. Strengthening the existing infrastructure facilities and develop additional human resources for providing high quality comprehensive eye care in all districts of the country. To enhance community awareness on eye care and delay stress on preventive measures. Increase and expand research for prevention of blindness and visual impairment. To secure participation of voluntary organizations, private practitioners in delivering eye care. Salient futures strategies adopted to achieve the objectives are continued emphasis on free cataract surgery through the healthcare delivery system as well as by the involvement of NGO sector and private practitioners. Emphasis on the comprehensive eye care programs by covering disease other than cataract like diabetic retinopathy, glaucoma, corneal transplantation, vitreoretinal surgeries, treatment of childhood blindness, etc. These emerging diseases need immediate attention to eliminate avoidable blindness from the country. Reduction in the backlog of blind persons by active screening of population above 50 years of age, organizing screening eye camps, and transporting operable cases to fixed eye care facilities. This third point is extensively followed everywhere across Tamil Nadu. The private government hospital, irrespectively, are making free camps at village sites and finding cataract in such population and mobilizing and shifting the population to their centers and doing cataract surgeries at free of cost. Refractive error compromises a major part of avoidable blindness. Screening of children for identification and treatment of refractive errors and provision of free glasses to those affected and belonging to poor socioeconomic strata. Even school teachers are educated in finding refractive errors in their class children. Refractive errors, early detection, early spectacle administration, early refractive surgeries will prevent blindness in children. Cataract is the major cause of blindness, treatable blindness in adult. Refractive error is the major cause of treatable blindness in children. Coverage of underserved area for eye care services through public-private partnership. This is what I mentioned through camps. Capacity building of health personnel for improving their knowledge and skill in delivery of high-quality health services. Information, education, communication, IEC activities for creating awareness on eye care within the community. Regional Institutes of Ophthalmology. For Tamil Nadu, it is Madras Medical College and medical colleges of the states to be strengthened in a phased manner with the latest equipment and training of manpower so that they can be upgraded as center of excellence in the regions. Madurai Medical College for South Division and Madras Medical College for North Division or Regional Institutes of Ophthalmology in Tamil Nadu, among medical colleges. The district hospitals to be strengthened by upgrading infrastructure, equipment, and providing adequate manpower like ophthalmologists, PMOAs on contractual basis and provide earned earmarked funds for basic medicines and drugs. Continuing emphasis on primary health care by establishing vision centers in second PHCs with the PMOA in position. Multipurpose district mobile ophthalmic units for better coverage. Vision 2020, the theme is right to sight. Targeted diseases are cataract, refractive errors, childhood blindness, corneal blindness, glaucoma, and diabetic retinopathy. Human resource development as well as infrastructure and technology development at various levels of health system. The proposed four-tier structure include Center of Excellence, Training Center, Service Center, and Mission Center. We will see in a pyramid later. There are three indicators to measure progress at national level. They are prevalence and causes of visual impairment as a global target, reduction in prevalence of avoidable visual impairment by 25% by 2019. From the baseline of 2010 has been selected for this action plan. The number of eye care personnel, cataract surgical service delivery, the cataract surgical rate, and cataract surgical coverage. So this is the pyramid which I told. Okay, the baseline centers are vision centers, which is 20,000 in number, service centers which are 2,000 in number, training centers are 200 in number, and center of excellence are 20 in number. So vision centers will able to see, check refraction and prescribe glasses and give primary eye care, school eye screening program, and screening and referral services, which means if anything above 3 services, they will screen and refer. Where they will refer to service center, which is 2,000 in number. There they will do cataract surgery, other common eye surgeries, facilities for refraction, and anything beyond these three will be referred to training centers, which is 200 in number. Tertiary eye care include retinal surgeries, corneal transplantation, glaucoma surgery, etc. will be performed here. Training will be given to physicians, surgeons here, and CMS will be conducted. Center of Excellence, professional leadership. Okay, any complicated cases will be referred here. Strategy development. These are the people who are going to develop strategy for rest of the India. Continued medical education, laying of standards and quality assurance research. They are also going to conduct research in the form of thesis and case projects. Okay. Next, iodine deficiency disorders program. The objectives of the program are survey to assess the magnitude of the iodine deficiency disorders in districts, supply of iodized salt in place of common salt. Nowadays, you are finding an advertisement, right? Unga paste la uppu irukka. It's like that only. Okay. Providing iodine. Okay. So why iodine is very important? Okay. Deficiency of iodine results in thyroid diseases, primary iodine deficiency goiters. You will find people with a huge neck hanging in front of the neck. All these are thyroidomegaly, primary iodine deficiency goiters, more prevalent in hill stations. Why? In hill stations, there will be running water, so there is no iodine in their water content. So these people are more prone for iodine deficiency states, iodine deficiency goiters. So after seeing this, the government implemented iodine deficiency, iodine optimization in their salt. Okay. So resurveys to assess iodine deficiency disorders and impact of iodized salt after every 5 years in districts. Laboratory monitoring of iodized salt and urinary iodine excretion. Health education and publicity. With this, we conclude this session of national health programs. Hope some other national health programs are covered by another person and rest are being given to me and I have covered it in this hour. It is bit boring, more of factual topic, but it is a part of your curriculum and it is our duty to make it cover for you, and I have done to my best. Okay, thank you everyone. If any doubts, I'm pleased to answer.
Good afternoon. Good afternoon.
Good afternoon, sir.
Good afternoon. Am I audible?
Yes, sir.
Is my slide visible?
Yes, sir.
Is my slide changing?
Yes, sir.
Thank you. Thank you. Thank you very much.
Welcome, sir.
Yesterday, we had seen about this topic outsourcing. I had given a glimpse about what is outsourcing. So it is a small topic. Usually outsourcing, you will be getting as a 5-mark question. So today we will be seeing in deep about what is outsourcing and how it is being done, what are its advantages. In MBA hospital management, in 4th semester, in paper 17, in the subject hospital facilities management, with a paper code MBHM4002. So in this subject, hospital facilities management, in unit 5, there is a topic, outsourcing of support services. So this topic we are going to deal today. Yesterday I had defined what is outsourcing. Outsourcing is the strategic use of outside resources to perform activities traditionally handled by internal staff and resources. So till yesteryears, if it is a hospital, all the functions of the hospital were carried out by the hospital staff. But as the hospital grows, as it becomes big, then for better efficient management, some of the services of the hospital are outsourced to professionals. And over a period of time, scientifically it has been proved that outsourcing reduces cost. Therefore, the practice of outsourcing is now extended to many services in the hospital. Why do a corporate company outsource? We can take it as, why should a hospital outsource its services? Number one, it reduces the cost by 36%. It conserves capital by 1%. It fosters innovation by 4%. So the time saving is 10%. The quality is improved by 13%. The hospital can focus on core services by 36%. So for the 6 reasons, in hospital, many of the services are outsourced today. In those days, in a hospital, if in a particular service, if they face a problem, then they would outsource it. But today, outsourcing has become a business strategy. In yesteryears, when the number of patients who turn to a hospital is more, the registration counter, the people in the registration counter are not able to provide comfortable services to the increasing number of outpatients in a particular busy hour. So then, to reduce cost, to avoid large capital investments, in case if the hospital is buying some sophisticated instruments and the funds have been diverted for purchase of sophisticated instruments and the resources become insufficient, then they would outsource the registration department. But today, in the modern world, in a hospital, they would like to focus on their core areas. Like if it is a hospital for orthopedic surgery, they would like to improve the facilities for orthopedic surgery, and for that, they need not waste time, resources in routine work. So the routine work that is being done is outsourced. And when it is outsourced, they have a liberty to give it to the person, to the professional who has the best technology. So the hospital can keep out with cutting edge technology. And the customer satisfaction also improves. And this hospital enters into partnership with the professionals in that particular area. So this networking helps. So in a hospital, as an efficient hospital manager, If we can outsource almost all the routine activities, then as a hospital manager, you will be very free. This is what is depicted in the cartoon. So what can be outsourced? System integration can be outsourced. Data network can be outsourced. Mainframe data center can be outsourced. Repair, annual maintenance can be outsourced. So like this, anything can be outsourced. So when should a hospital outsource what? So for that, we make use of a model that is called as Price Waterhouse Coopers model. So in this, you can see those services which are strategic and those services which are competitive, they are not outsourced. Like for example, as I mentioned, you can take an example of an orthopedic hospital. So the orthopedic services that they offer, the orthopedic surgery, that is strategic, that is competitive, that cannot be outsourced. So physiotherapy, that is non-strategic but competitive, so it is a gray area. So that also we will not outsource. Post-operative care, so that is strategic but non-competitive. So we will, as far as possible, try to do it as an in-house. Registration of patients, so that is non-strategic, that is non-competitive, so that can be outsourced. So usually what is non-strategic and non-competitive is outsourced. What is strategic and competitive is not outsourced. What is non-strategic and competitive can be outsourced, but as far as possible, we will try to do it with in-house. Strategic and non-competitive, we will do it by in-house because it is strategic. How to implement outsourcing? So initially, the hospital manager will have to find out what services can be outsourced. So the opinion of the other stakeholders are taken. The idea is shared to the management, and then a draft contract is prepared. So this phase is called as program initiation. The next is program implementation. So the staff who are currently performing that particular service which has to be outsourced, so they will have to be transferred. So where they should transfer, where their services is required. So they will have to give inputs and take care of the initial teething problem when a particular service is being outsourced to a third party. So for that, they should be available, and at the same time, their services should be optimum utilized. The hospital will have to enter into a service level agreement. So what all should be mentioned in the agreement? So for that, they should have a brainstorming session. The hospital should enter into a communication with the service provider with whom they are going to enter, whom the service is being outsourced. So they should establish a communication. So from the hospital side, there is a one source of point contact, and from the service provider, there should be one source of point contact. So they should establish good communication network. And then comes the actual transfer of service. The management procedure for overseeing the quality of service provided by the outsourcing agent and how they can improve. The problems faced by the outsourcing agent has to be discussed with the hospital, and together they should come out with some viable solutions. So all this comes under program implementation. This is the second phase. The third phase is contract agreement. The hospital actually enters into a contract with the third party professional service provider. And then the last phase is contract fulfillment. The outsourcing agent takes up providing service to the hospital in a professional way. So that is called contract fulfillment. What are all the problems that we face with outsourcing? Number one, the hospital will lose control over the particular service. Like for example, if they want to outsource registration, when it was done by in-service candidate, so when a known person, when a VIP to the hospital enters, so the hospital management will have an upper hand in bypassing that VIP and carrying out the registration. But when it is being outsourced to a third party, to a professional, then the hospital would not have control in registering that VIP, and they would not be able to act as per their whims and fancies. Suppose if the billing section is being outsourced, and suddenly if there is more cash receipt, if the management wants to divert that cash for some philanthropic activity, so when it is being outsourced, a third person also knows the cash flow in the hospital. So the confidentiality of the cash flow to the hospital cannot be maintained, and that would also lead to a security threat. Suppose if the hospital has outsourced the purchasing, usually they don't do purchasing. In case if the hospital management has a soft corner for a person who is a regular supplier, so in that case, the hospital will not be at liberty to select the supplier. Once outsourced, after a few years, the hospital is dependent on the service provider. So the skill of the in-house person is lost. Tomorrow, in case if the service provider stops his services for some reason, so that will lead to a lot of problems. Slowly, the hospital will fail to understand the ground reality of the services where it has been outsourced. If the hospital wants to introduce a new change in a particular area that has been outsourced, the hospital management will not be able to do it instantaneously. They will have to update this with the service provider. The service provider will have to agree to this. Accordingly, the contract will have to be changed, and then the updation in the service providing can be done. But on the contrary, if the particular service is being provided by the hospital, then if they want to update it, if they want to change it, they can do it immediately. The time lag will not be there. Here there is a beautiful cartoon where a hospital data entry operator wanted a special cable for his computer, but as the procurement services has been outsourced, instead of giving a high quality cable, he purchases a very low quality cable, and the hospital data entry person is unsatisfied with the quality of the cable that has been provided to him by the outsourced procurement agency, but still he will have to move with it. He expresses his dissatisfaction with the hospital management, but the hospital management immediately cannot do anything because they have outsourced procurement. So what that procurement outsourcing agency does, they will have to bear with it till it is sorted out, and that will lead to some time. Suppose in case if a hospital is outsourcing its website, so slowly the bandwidth, the IT professionals who are handling the website of the hospital, the softwares and hardwares used in the hospital, the CCTV cameras that are monitored in the hospital, 24/7 support. So everything will be under the control of the outsourcing agency. So when all these vital services are outsourced, we will have to work out the total cost of performing these activities using in-house staff and the total cost involved in outsourcing these activities. For that, for each and every activity, what is the activity cost? Is it inclusive of labor? What are all the overhead charges? What are all the raw materials that would be required? What would be the cost for shipping the raw materials? Where the raw materials will have to be stored? How it will have to be handled? What is the overhead cost of the invested capital? What is the impact of outsourcing on cost and revenue? So all this we will have to put together and make it as the total cost of performing activity in-house. When that same activity is outsourced, so now it is okay, but in future when we are going for renewal, at the time we might have lost our skill in carrying out that particular activity, but that outsourcing agency may take an advantage of it and increase the price. So what would be the future pricing? So that will have to be kept in mind before outsourcing. So when a database is being outsourced, the clinical area, the preventive care area, the ongoing support area, and the enhancement care area. So these and all are some strategic areas. Though the cost is reduced by 25 to 40%, the data is stored off-site. So there could be a security threat. In many hospitals, the emailing services is outsourced. Like for example, if it is a cancer hospital, after registration to the registered patient, they sent an email that this is the registration number of that particular patient. And when the patient has undergone some test, the results of the test are sent as an email to the patient. Later, when the patient goes back and when he has to come up for a follow-up, so a reminder for the follow-up is given through the email. Any updates in the services given by the hospital to the patient is also updated to the existing patients through email. So for sending all these emails, in many hospitals, they outsource the services. So the total cost of ownership for an in-house email system is likely to be in the range of $200 to $400 per user per month. Outsourcing reduces it by 10 to 30%. So this outsourcing takes care of the 24/7 web-based support, the spell check in all the email forwarding, unlimited attachment size, unlimited storage folder, multiple attachments, virus scanning. So all this are taken care by the email outsource service provider. Here they have taken a case study, a typical service that is a custom webmail that is being outsourced, and how they calculate the cost. The web-based email services with 6 mailboxes, so the cost is worked out. If they want to have a wireless access, if they want to have additional storage, what would be the cost? So that cost is worked out. The salary component, the space component, the continuing education component, the maintenance component, the repair component, everything is worked out. And then it is outsourced. Initially, in the healthcare department, medical transcription was outsourced. Medical data entry was outsourced. Nowadays, most healthcare facilities are outsourced. Like, for example, clinical research, healthcare information, management system, medical billing, information technology. So all these services in a hospital are being outsourced. What are the advantages of outsourcing medical billing practices? We will take one as an example. First of all, outsourcing services can help avoid serious mistakes. For a hospital, medical billing will be new. So they may commit errors, mistakes, but when it is outsourced to a professional who are in the field, so they would not commit serious mistakes. Because they are professionals in that particular field. A lot of hospitals lose a lot of money annually because of poor medical billing practices. This is mainly caused by medical bills that have errors. There are some hospitals that do not stay up to date with the changing billing rules and regulations. So the billing rules and regulations keep changing. As a result, they end up making errors that could be easily avoided. When medical billing services are outsourced to professionals who only deal with that particular area, we can be sure that critical billing mistakes can be avoided. Another one advantage of outsourcing is it reduces training cost. If we outsource non-medical processes in the healthcare organization, we will not need to worry about setting a lot of money aside to train staff on how to handle those operations. The outsourcing partner will see to it that their employees are up to date with any changes in the standards and regulations. Since the outsource agency will not impress the hospital management, they would keep their services up to date. And they will also ensure that they provide good customer satisfaction. Outsourcing also saves money. If we are doing that particular service with the in-house employee, we will have to pay a salary for them, and that salary keeps increasing month by month, the other benefits, and after retirement, the post-retirement cost. So all this can be reduced when it is being outsourced. So with this, we complete this small unit on outsourcing of support services, and then we will take up the next unit. This unit on waste disposal and management. This waste disposal and management is also in MBA 4th semester, paper 17, hospital facilities management, paper code MBHM 4002. Under unit 5, there is waste disposal and management. It is very important. Almost in all the examinations, there has been a question on waste disposal and management. So practically, a hospital manager will be facing number of problems in waste disposal and management. So he should be thorough and updated with all the information that is required for waste disposal in a hospital and its management. So we will deal in detail about waste disposal and management in the next half an hour. Is my slide on hospital waste disposal and management visible?
Yes, sir.
Participants?
Yes, sir.
Is it visible?
Yes,
Yes, sir.
Is it changing?
yes, sir.
Yes, sir.
Thank you. Thank you. So kind of you. Thank you. Thank you. Now, we are going to deal about a very important topic, hospital waste disposal and management. I would like to start this topic with a beautiful quotation from Park. Physicians will appreciate the great book Park and Park. So that Park has a beautiful quotation. Let the waste of the sick not contaminate the lives of the healthy. A beautiful quotation. Let the waste of the sick not contaminate the lives of the healthy. What are all the objectives of waste disposal and waste management in a hospital? Number one, we will be dealing about the definition of hospital waste. As per the World Health Organization, how to classify hospital waste. What are all the sources of healthcare waste? We will take one case study of how healthcare waste is being managed in Nepal. We will see into the magnitude of problem in developing and developed countries in hospital waste management. We will also list the problems associated with healthcare waste. We will also go into detail about generation of hospital waste, segregation, storage, transportation, treatment, and disposal. What are all the treatment techniques and categorical treatment available? So all such things we will be dealing in the next class. Now, we will see the definition of hospital waste. Hospital waste or the waste produced in the course of healthcare activity during treatment, diagnosis, immunizing human being or animals, or while doing study or research activities. So hospital means not only for human, even in a veterinary hospital, they will be generating a lot of waste. So that waste will have to be managed. In a hospital, 75 to 90% of the waste that is generated is non-hazardous, general waste. But the 10 to 15% of the waste is hazardous, infectious. They can cause disease. So they will have to be very carefully treated. World Health Organization is classifying the hospital waste into 6 types, 6 categories. The first one is called as general waste. In the office of a hospital, if there is a waste paper, in the hospital, the wrapper of the various dressings, the kitchen waste, the general sweeping waste, they and all are called as general waste. They are not at risk to human health. So that is why the World Health Organization has categorized this as general waste. No risk to human health. In a hospital, in the operation theater, human tissue, human fluid, body parts, blood, all this could be collected. So that is called as pathological waste. Infectious, which should be handled with care. In a hospital, especially in the injection area or in the operation theater, needles, scalpel, knife, blade, etc. are being used. So it is called a sharp waste. While handling sharp waste, we should be doubly careful. Otherwise, the person who is handling the sharp waste, he may get injured, he may get infected. In an infectious ward of the hospital, the waste that is generated can transmit bacteria, virus, or fungus. So such waste, which is suspected to contain the pathogen, like for example, a laboratory culture, a swab, a used bandage, infected tissues, they all are segregated as infectious waste. In the medical lab of the hospital, chemical waste will be generated. The laboratory reagents, disinfectants, film developers. In the radiology department of the hospital, radioactive waste will be generated. Unused liquid from the radiotherapy or from the research lab, contaminated glasswares. So, in your examination, the key word is hospital waste can be classified into 6 types. Number 1, general. Number 2, pathological. Number 3, sharp. Number 4, infectious. Number 5, chemical. Number 6, radioactive. There are some other waste, like for example, pharmaceutical waste. In the pharmacy, the expired drugs, they all become pharmaceutical waste. In the hospital, there could also be pressurized containers, gas cylinders, aerosol cans. So they should be handled very carefully, otherwise they will burst. Genotoxic waste, like for example, in a cancer ward, the cytotoxic drugs that are used in cancer therapy, they will have to be disposed of very carefully. The current trend is the sharp waste is also to be considered as an infectious waste. because on the sharp point there could be a blood, there could be a body solution, so that could house some infections. So it has to be treated as an infectious waste. What are all the sources of healthcare waste? So first is government hospital, then the private hospital, then the nursing homes, the physician's office, the dentist office, the dispensaries, mortuary, blood bank, blood collection center, animal house, laboratories, and research organizations. WHO has published one book, National Guidelines for Healthcare Waste Management, in 2002 on behalf of the Ministry of Health. In Nepal, the Kathmandu metropolitan city, they have also initiated a plan for managing the healthcare waste. So we will take this as a case study and study this. From this study, they were able to find out that on an average, in one hospital, for one patient per day, 1.72 kg of waste is generated. So this is a very important data. With this data, we will be able to manage the waste. The second vital information that has been generated from this case study is that out of the total waste generated in a hospital, 26% is infectious and hazardous. The rest are general waste. From this study, the third vital information that has been generated was non-degradable medical waste. There is a saline bottle that forms 12%. Biomedical sharp, which is supposed to be treated as an infectious waste, that is 3%. So if you take worldwide, the developed countries generate 1 to 5 kg of waste per bed per day. In developing countries, this is less, 1 to 2 kgs per patient per day, but the data available is very less. WHO has clearly segregated that in a hospital, 85% of the waste is non-hazardous, 10% is infective waste, and 5% is non-infective. But in India, at a national level, such studies are still to be done. If you look at the category of people who are exposed to this hospital waste, the first one is the patient and the visitor. The person who is actually affected is the sanitation worker. Next is the medical and paramedical staff. So these three people are exposed to the risk of infection by a hospital waste. What are all the routes of transmission? Number one is inhalation. In a hospital, when they are sweeping, when they are brooming, the inhalation of dust particles containing germs will infect the patient, the attender, the hospital staff, and also the sweeper. So if there is contact of the waste with the intact or non-intact skin or the mucous membrane, so then it is very serious. In case if there is an accidental ingestion of the contaminated material, either because of unwashed hands or because of handling drinking water. So then that has to be dealt with extreme caution. So inhalation, contact, and ingestion. So these three are the sources or route of transmission that are very much worrisome in a hospital waste management. What are all the organisms that cause disease, that create a problem in biomedical waste management? What are all the problems associated with biomedical waste management? Number one, AIDS. Number two, hepatitis B, A, C, arbovirus, enterovirus, herpes virus. So all these viruses, they cause major diseases like AIDS, hepatitis, dengue, encephalitis, ocular infection, and genital infection. So in a biomedical waste, the infected needles, the body fluid, the human excreta, blood, eye secretions, genital secretions, they may all be infected with these viruses. So utmost care must be taken in disposing the infected needles and body fluids. Apart from viruses, bacteria such as Salmonella type B, Vibrio cholerae, tetany, Pseudomonas, Streptococcus, they all cause typhoid, cholera, tetanus, wound infections, septicemia, rheumatic fever, endocarditis, skin and soft tissue infections. So these bacteria are usually found in human excreta, body fluids, sharps. So they will have to be dealt doubly cautious. Parasites such as Wucheria bancrofti, Plasmodium, they cause filariasis, Kala-Azar, malaria, leishmaniasis. So they could be present in the human excreta, blood and body fluids. So if the hospital sewage system is not properly managed, then they could be infecting the other healthy people. So in a hospital waste management, the very important thing is taking care of waste generation. Next is waste segregation. Then waste collection. Then waste storage. Very important one, waste transportation. And the most important one, treatment of waste. For all this, there are standard operation procedures, though there could be some small variations, but in general, they are all the same. First, we will see about hospital waste generation. As we saw in the classification of hospital waste, there are two types of waste that is being generated. One is hazardous and another one is non-hazardous. Non-hazardous waste is generated in the office, in the kitchen, in the administration, in the hostel, in the store, in the restroom, that are disposed by the municipal authority. But a hazardous waste that is coming out from a ward, from a treatment room, from a dressing room, from an operation theater, from an ICU unit, from a labor room, from a lab, from a dialysis room, from a CT scan room. So they have to be disposed of by the hospital itself. In some cases, even this is being outsourced. The next important thing is segregation. The waste will have to be segregated at the point of waste generation. The waste has to be put in separate colored bags. Color coding varies from state to state, nation to nation. But all in India, All India Institute of Medical Science, they have given a beautiful uniform color code. Number 1, the waste basket for disposal of general waste. That is black. Cardboard boxes, wrappers, paper, kitchen waste. Everything comes in a black bin. The next one is the yellow bin. Yellow means infectious waste, pathological waste, soiled linen, contaminated gown, drapes, swab stick, dressing, bandages, human anatomical waste. So all this comes as infectious waste, or it is also called as pathological waste. We saw about black bin, then we saw about yellow bin, and now we are going to see about blue bin. The needles, the blades, the scalpels, all sharp items. They are all disposed in the blue bin. While disposing sharp items, we must be doubly careful. Nowadays, in many injection rooms, you can see that after injecting, the needle is made blunt with the help of a machine, and then the sharp is disposed of. So the person who is handling the sharp waste, he should be trained. He should be given with all the protective equipment to protect himself and his hand. So sharps, they are a dangerous source of infection. So they are infectious waste. So next we will deal about waste segregation. So your white bag is used for segregating IV sets, blood and urine bags, syringes. A yellow bag is used for segregating infectious waste, soiled bandages, dressings, tissues, placenta. A black bag is used for general waste. How to collect the waste? Centralized sanitation staff collect the waste during the morning, afternoon, and evening under the supervision of a nursing staff and a sanitation supervisor. While infectious staff is being collected, it should be properly documented in the register. There must be also one register to record the cleaning and disinfection of the garbage bin, because that should not become a source of infection. There is a general rule that waste should not be stored in the generation area for more than 4 to 6 hours. That is why in a hospital, they collect waste in the morning, afternoon, and in the evening on all days, including holidays. Sometimes there are conditions where the holidays are for a number of days. Like for example, today is Gandhi Jayanti, yesterday was Sunday, and then Saturday. So like that, the number of holidays are more. So in that case, if the waste collection people do not turn up, then waste will be stored in the collection area itself for a long period of time. That may lead to infection. So it is a responsibility of the paramedical staff and the sanitation staff to check that the waste is segregated at its source. The waste that is collected from various areas is transported to the waste treatment plant. The transportation of waste is very, very important after it is being segregated. So for waste transportation, there must be a separate corridor. separate lift. General waste, they are deposited at municipal dumps. Waste for autoclaving and incineration are dumped at separate sites. So when such infectious waste are being transported, they are done in sealed container under the direct supervision of the sanitary supervisor, who satisfies that there are no leakage. So for identifying the waste and for waste treatment, labels and symbols have to be used. Whether the waste is a risk of corrosion, whether the waste is a danger of infection, whether the waste generated is toxic, whether there are glass pieces, whether there are radioactive materials, or this have to be mentioned in the label. On the screen, you can see the biohazard label. So on the screen, you can see the cytotoxic label. So when these labels are there, the waste should be handled with great care. The labels should be non-washable and prominently visible. What are all the treatment and disposable technologies that are used? Number one is incineration, burning it. Number two is chemical disinfection. Immerse the tissues, blood in a chemical so that all the microorganisms are killed. Wet and dry thermal treatment. Microwave irradiation, land disposal. We will see each and every technique. The first one is called as incineration. High temperature dye oxidation process reduces organic and combustible waste into inorganic and incombustible waste. So the volume and weight is reduced. So now the waste that cannot be recycled, reused, that can be only disposed in land, they will have to be segregated and kept aside. So when we burn a hospital waste, it will lead to heat, gas and ash generation. For infectious waste, we should use a double chamber incinerator. For normal waste, they use a single chamber incinerator. If they have a very contagious infectious waste, then they make use of rotary kilns for genotoxic waste. Commonly used liquid waste, blood, urine, stool, hospital sewage, they are all disinfected with chemicals so that the pathogens in these waste is killed. We will see about wet and dry thermal treatment. Steam disinfection is the best treatment that can be given for medical waste, provided if the waste is exposed to high temperature, high pressure steam, similar to autoclaving. Hospital waste is shredded to reduce the volume, and then it is heated in rotation, where there is a 20 to 35% reduction in waste. We still need to deal about microwave irradiation, land disposal. The treatment for the various biomedical waste as per their category. So to deal this, I may need more time. So tomorrow between 3 to 4 in my class, the first 15 minutes, we will dedicate for the other methods that are used for treatment of medical waste. So thank you very much for your patient listening. If you have any doubts, you can ask me, or we will meet tomorrow afternoon at 3 p.m. Thank you. Thank you. Thank you, Mr. Lewis. Thanks to one and all. So we will meet tomorrow. Thank you. Thank you, Arun Muni. Thank you, Isai Tamil. Thank you for your participation.